Marco, tudo bem? Na hora que vocês derem ok, a gente começa. Okay, so I'm going to speak in Portuguese first and in English, ok? Bom dia a todos, é um prazer enorme estar aqui hoje. Eu estou falando em nome do atual coordenador do programa, o professor Márcio Lopes. Infelizmente, ele não pôde estar aqui presente nesse momento, mas ele vai chegar no período da tarde com o Nicolas Nictax. Ok? Então, a palestra do Nicolas será no final da tarde. O Ali está chegando, mas nós já temos os 3 palestrantes aqui, o professor Willy, o professor Alex e o professor César. Então, nós vamos começar agora com o professor Willy, depois o professor César e o professor Alex encerra essa manhã, tá bom? Nós estamos muito felizes em poder completar 25 anos como programa de pós-graduação. Isto mostra, né, a importância dessa data para nós. Sem dúvida, hoje nós somos conceituados como 7 na CAPES, que é o conceito mais alto dentro dos cursos de odontologia, que significa que é um curso de nível internacional. Então, nós estamos muito felizes com isso e vamos fazer essa atividade hoje com vocês para celebrar esses 25 anos. Agradecer mais uma vez a Leonor por esses presentes que ela fez e trouxe de Medellín. É Medellín, Alan. Medellín, em Colômbia, né? Então, a gente agradece muito por essa cortesia. Ficou muito bonito. Obrigado, viu, Leonor? E também agradecemos a presença de todos aqui, a presença do Paco, da Sarai, do Jerônimo. Então, nós temos México, Argentina, Estados Unidos, Brasil, África do Sul, presença do Narciso também, que veio de Santos, acordou às 5 horas, professor Jacques, que está lá no fundo agora, chegou. Eu vou perceber que está brilhando um pouco. E também todos os alunos e amigos, o Marcelo Esperandil e André Caroli, que aqui também está e trouxe o Alex e o César para a gente. Então, muito obrigado a todos, realmente. Okay? So, it's a great pleasure for us to celebrate the 25th anniversary of our postgraduate program in Estomatopatology. We are going to start our academic activities today with Professor Willy van Heerden. After Willy will be Cesar and Alex in this morning. We have to move our schedule because Nicolas Nictax, he couldn't make it this morning, but he's going to arrive in the afternoon. Okay, so he'll be the last talk with the speakers because it's important and make the activity more vibrant. Okay, and we are very happy for celebrating 25th anniversary of our postgraduate program. Thank you for our students, our professors, and our team. I would like to thank Marco and Felipe that they are recording this activity for everyone that will follow us on YouTube. Okay? So thank you very much. Let's start with Willy van Heerden. Willy, it's a great pleasure to receive you again in our postgraduate program. You've been here many times, and we celebrated our 20th anniversary, and you are here celebrating the 25th. We always will be in that with you because we've been a great partner of our program. You receive a lot of students. You teach us a lot, so it's a great pleasure to have you with us.
Thanks, Bob. Good morning, everybody. First, my thanks to the invitation. It's really kind. Thanks, Pablo, Alan. As Pablo said, this is my 5th visit to Brazil. And throughout the years, we had a really special relationship with Piracicaba. We were fortunate to host a number of postgrad students, many of them who are here this morning. And so it comes a long way. First of all, you have to excuse my English. It's my second language, so I'll try to keep it as simple as possible. I know people in my country have difficulty understanding me, so good luck with that. Please also take the liberty of interrupting me when you want to ask a question. As Pablo said, it is informal, so we're not going to, you don't have to wait till afterwards and so on. Right, so the first of my talks, okay, yeah, let me just say I have been for many years at the University of Pretoria, was the head of department there for 27 years, had to retire when I reached age, and currently I'm part-time head and neck pathologist with PAF Care for Mark, one of the private firms, just to keep one busy during the day. But the first topic is on odontogenic cysts and a non-odontogenic cyst of the jaws. And I recalled when I looked at this, it was in 1994. We had the IAOP meeting in York, and we were sitting there, and the late then Prof. Jens Birnborg sat behind us. And I think my presentation that time was on multiple myeloma and detecting all the abnormal proteins in saliva, which was fairly novel and so on, and went back and he congratulated me and he said, yeah, you know, we as oral pathologists, we tend to look at soft tissue sarcomas, we want to work on lymphomas and so on, but we should never forget the basics of the core of a specialty, odontogenic cyst, dental abnormalities and so on. And that stick to me. So it's basically that we looked at that things like caries and so on. One tend to forget. You concentrate, and I'm guilty. If you look at my publications, most of them are not so-called fancy stuff. But this is the core of that, and it's basic. And I think so. I'm most likely not going to tell you anything new today, but sit back, enjoy some of the imaging and so on. Right, if you look at the latest book of Paul Speicht called Shear's Cyst, and Mervyn Shear, as you may have known, is South African. I was fortunate to know him quite well, a very exceptional person. And this is nothing new. This is the basic classification. And we're going to quickly run through some of them and to talk some of them. Nothing new, nothing controversial. This normality has returned into the classification of cysts, and we'll come back to that. What is important, and that is for all our students, is please, if it's not part of your formal training or whatever, take a week or whatever and make certain you understand completely, linked to the histology, odontogenesis. That is the core of odontogenic tumors, of cysts and so on. Know what exactly is going on and what is sequenced. So it is such a beautiful thing. Know, for example, if you look at mixed tumors, you don't get such a thing as a myeloblastic fibroenameloma. Why? You'll never find enamel without dentine. So know that sequence in odontogenesis. And when you have time and you get an odontoma, just do a mason on that. It's so beautiful to have a ectodermal component of enamel with a mesodermal component, just with different stains in a plain, simple mason on odontogenic or teeth lesions. It's beautiful to look at. Right, that being said, radicular cysts. And I think I really appreciate it since with almost 2 years that I've been working in private, is the importance of radicular cysts. When you're in academia, you very seldom get radicular cysts in the biopsy service, but it is incredible out there, the amount of that you see. So it's almost a bread and butter stuff. So, yeah, it's normally asymptomatic. It may be symptomatic, obviously, due to infection, if it's linked to secondary abscess formation and so on, and can be quite large. And as you all know, it's the most common of the odontogenic cysts. This is a typical presentation where you see there's a fractured tooth there, led to a non-vital pulp, and you get the lesion. So the key again with radicular cysts, it is linked to a non-vital pulp. If you look at the information from a study, so it was done from combining a South African sample with Sheffield from a latest book of Shear. As expected, most common are in the anterior teeth in the maxilla. Why? It's not because they are mostly affected by caries. It is trauma. And it will be the case in Brazil as well. Football is a huge sport here. And guys are not always, youngsters concentrate. They want to hit a ball and they mistime it and get a nice bump on the jaws. So most of the cases will be due to trauma. You get a dead pulp in the anterior teeth with a resulting radicular cyst. And so it goes down to the different teeth in the areas. The pathogenesis is well known. Nothing has changed over the last number of years. You have a necrotic pulp, you have the granulation tissue formation, and due to that you get, due to inflammation, stimulation of epithelium, and the epithelium can be from cell rest of molasses, and may also be from a sinus lining in the case of maxillary teeth, or some other fistula tracts as well. And also remember, you can get a radicular cyst adjacent to a tooth, which will come into the differential diagnosis of a lateral periodontal cyst, but we'll come to that. So these are the cell rests of molasses. When you get the sections and you get teeth in that, have a look in it. It's always nice to see. And what it actually is, it is like a mesh, a network of epithelium. It's not individual islands. You see it like this because you're looking at a two-dimensional stain, but it is like a mesh, a network around the tooth in a periodontal ligament. That is where the cell rests of molasses, what they are, and which is the main source of the epithelium in a radicular cyst. And this is typically, you have a non-vital pulp, and then it presents radiologically as a radiolucency, and you get extraction. If you're happy, you get it attached to a tooth. Let me see on this stage, there's no way you can clinically or radiologically distinguish between a radicular cyst and a periapical granuloma. They can look at size, but I can tell you smallest lesions can be a radicular cyst and vice versa. Again, another example of that, anterior teeth. Always remember, and that's a classical undergrad student issue, if you see a periapical anterior mandibular, also think of periapical cementoosseous dysplasia. Vitality is important. Always do it. In this case, you can see there's been an attempt at root canal treatment and tooth is non-vital. You can also see it with the open apices. And again, these radiology features. The guy's got a couple of problems on both mandibular and so on. And while we're on the topic at this stage, please remember, you cannot use a radiograph to evaluate the success of a root canal treatment. You see so many times people see a tooth with a periapical radiolucency, the tooth is non-vital, perform a perfectly endodontic treatment, and the lesion doesn't disappear, and say, look, that root canal treatment is unsuccessful. That's nonsense. If you have a radicular cyst, it's not going to disappear with a root canal treatment. End of story. So I think that is a message you have to get across to your things. And they'll show you, look, but look at this case, it has resolved. But how do you know it was a radicular cyst? It was a periapical granuloma. So a radicular cyst, when you have an epithelial lining, it's not going to resolve with endodontic treatment. You have to go in, remove it, maybe do an apicectomy, and get the tissue out. So that's very important. You cannot use that, irrespective of size. As I said, a radicular cyst can be very, very small as well. And this is typically what you'll see. The epithelium is proliferating, and if you're lucky, you may find these arcading retape processes with bricks formation, and then always linked to the inflammatory cell infiltrate. In practicality, you may find sometimes, and actually more often than not, a large lesion, which a surgeon, you have to know your clinicians, they say it was definitely a cystic lesion. You get that, and you cannot find epithelium for life of you, even on several sections. Now, do you call it a granuloma, or do you call it a radicular cyst? And I'm not certain in this country, but there is financial benefit for the surgeon if it is a radicular cyst, because when it is a cystectomy, they get more money for that rather than to do a periapical granuloma. So you don't want to help the guy by being dishonest and so on. But what we see, if it's clearly a cystic lesion and you can see it when you put it through, that it is a cyst wall and you cannot find it, that's fine to call it compatible with a radicular cyst. I personally don't call it a definitive radicular cyst if I see no epithelium, but I'll call it compatible with. And we see quite often where we find epithelium, large areas where the epithelium is ulcerated. So it may just as well be that the whole epithelial lining is ulcerated. So that's fine. So just make up on the radiology, it should be large, and then on the clinical impression that they said it was a cystic lesion and you got a cyst wall as well during put through. Again, you'll find that, and typically you'll see the neutrophils in the epithelium and then a mix infiltrate subepithelially, quite often with microabscess formation as well. Quite frequently you see some hyaline ring angiopathy or pulse granulomas, just mean there's exposure to foreign material with that. Residual cyst is fairly simple. That is just a radicular cyst where they have removed the tooth and the cyst remains. So they extract the tooth, left the cystic cavity, and it's left behind. So we don't see it that often, but this is a nice example case. So that tooth was extracted, not curetaged, the socket, and you remain behind with that cystic lesion. So obviously you cannot have a necrotic tooth associated, but there's an absent tooth, and then the radiological support of that. Just remind, because you quite often may find that, it's not so rare, that if you have a child case that you may have a radicular cyst associated with one of the primary teeth, and then the teeth extracted, and then that permanent tooth, and most likely there's a cystic cavity, they erupt into that cavity. And then you said, are we dealing with a dentigerous cyst or not? Because that tooth is not so clever. There's suddenly a lining on top of it, they erupt, they say, well, we've arrived a little bit early, but we're now in the oral cavity. So that can be quite difficult, and it's almost impossible to make the distinction between an inflamed dentigerous cyst versus a residual cyst with a tooth erupted into it. I think you need the history and good communication, and then tell the clinician, look, my take on it, if a tooth is still within its normal, it's not expected yet, then to call it an residual cyst. But time-wise, if it is clearly impacted, it should have erupted and it's not there, then you may think of an inflamed dentigerous cyst. Paradental cyst, also fairly common that we see. Fortunately, it's clear on radiographs. Again, so it's typically linked to a partially erupted third molar. That is what you'll see clinically and macro put through. And this is a typical radiology. Partially impacted wisdom tooth, you get pericoronitis, the inflammation there, and usually distal you get the radiolucent lesion there. Again, it is so important, and I'm going to stress it in a number of my talks. Get clinical information and get a radiograph. The clinician has a radiograph. There's no reason for them not to submit it to you. Nowadays with cell phones, if they can't send it and so on, they can put it up or just take a photo on a cell phone and send it to you. So please get into the habit of not diagnosing a lesion without a radiograph. The only one who's going to lose out is yourself. One day that you're going to make a mistake and you said, but you didn't have a radiograph. That is no excuse. Then the reply would be, why did you diagnose it? So get a radiograph on anything or a clinical photo that you look at under a microscope. Yeah, my hobby, one of my hobbies is scuba diving, and I like to take photographs underwater. So you'll be confronted with some of them. There's always in every crowd an odd one out. Right, gingival cyst of infants. You're not going to see it a lot, but it may be that you are consulted by a family member being an expert in this field and so on. So there are basically two types. It's referred as bone nodules, which it is on the alveolar ridge. It's remnants of the cell race of serous. Remembering cell race of serous, if you look at the dental lamina going down in odontogenesis to form a tooth bud, you get, and when it breaks up, that dental lamina, it's known as the cell race of serous, and they are present in the gingiva as well as in bone, because it comes from the epithelium into the then developing bone. So you're always going to find cell race of serous in soft tissue as well as in bone. One tends to forget that it may be in soft tissue. So when you find it there, it's actually just small keratin filled. You're not going to biopsy it, you leave it, you reassure them. But on the alveolar ridge, and there's small tooth and there's a small bone nodule as well. And then when they are on the palate, it's not ontogenic, it's just a fusion of the palatal processes during development that you may get few, it's not common, also trapped epithelium with some keratin. No treatment necessary, but these are called Epstein pills for that. Just a giant moray eel and some companies. Now, OKC, I think so much has been written about an odontogenic keratocyst. It is a developmental cyst, fairly common, about 11% of all cysts. And then the typical features, classically in the mandibular molar region, usually asymptomatic. Some may appear more aggressive than others. And then 10% have multiple cysts, which will come to basal cell nevus syndrome. We'll come to that. Radiographs, typically unilocular, but it can be multilocular as well. And then one of the typical features, and like in pathology, there are always exceptions, but you can have a fairly large lesion, but it tends to grow intramedullary without expansion. So if you see a lesion with expansion, you cannot exclude it, but it's most likely not an OKC. So it can have a variety of features. This is a typical feature as well. It is posterior. You see it's fairly large, unilocular, but not expansion. You cannot evaluate it on a two-dimensional pan, but there's no expansion. Again, here, it can be linked, look like a dentigerous cyst. You may think a unicystic ameloblastoma. It's multilocular. You may think of an ameloblastoma as well, but this was an OKC. Again, quite large as well, associated to serum-impacted teeth. You're not going to think OKC first. You think of a number of other odontogenic tumors. And the histology is fairly typical. This is a nice case, no inflammation. You have a palisaded basal cells, cuboidal, and then maturation, 4 to 5 layers, to a corrugated parakeratin layer. This corrugation is fairly typical, etc. With high magnification, you may see the odd mitotic figure, but nice parakeratin production, fairly typical. Then you have to be on the lookout for budding. This is excessive budding. The moment you see budding like this, be on the lookout if you're not dealing with a syndromic patient. It's not always the case, but most patients where you have budding may be a syndromic patient. And always be on the lookout if you get a cyst that is inflamed, because the moment you get inflammatory cells, the typical features of an OKC disappear and it becomes non-specific. So if you have an inflamed cyst with only that non-specific lining, really put through all the reserve, be on the lookout to find a typical area that is not inflamed where you may find the typical OKC features, and that will normally help you with that. Just again, the pronounced budding and so on. It's not early invasion, don't overcall it. And then you can find in the cyst wall a lot of epithelial islands, odontogenic epithelial islands. You may find a number of daughter cysts as well. This is not a keratoameloblastoma, don't confuse it. ignore the concept of a solid OKC. I don't think it exists. So it's just a number of daughter cysts in an OKC. Again, when you see this, think of the syndromic patient, but it may be a basal cell nevus syndrome patient. That's important. And then typically, apologies, you have, in all cases, the subepithelial cleft formation. It's not pathognomonic, but it'll help you and so on. It's just a nice thing to describe to a surgeon. It's very, very common to find at these cleft, and there's a lot of reasons that have been published to do why it's the case. What I always do if you look at an OKC is to comment on the absence and the degree of dysplasia being present. It can be quite certain that you can pockets where you can find up to severe dysplasia and so on. And it's difficult to design studies to evaluate the implication thereof. But I think it's important to do that, and so that the clinician can have regular follow-up. You can see there's really a pocket, the area of quite pronounced dysplasia, where you do not have normal maturation, as you would expect. Well, a diagnosis of syndromic patients, I think that's fairly clear how to do it. Basically, you need two of what is said major criteria, or one major and two minor criteria. And the major criteria, if you have more than two basal cell carcinomas in people under 20 years of age, you know it's the most common malignancy of skin, but very seldom that you find it in young people. So if you have it in a person younger than 20, if you have got more than one OKC. Personally, if I have a patient with two OKCs and nothing else, I will still consider that to be a basal cell nevoid syndrome. Because in any syndromes, you have a degree of expression of that. So I will do that. And then this palmar or plantar pits. And then obviously, if you do a radiograph, you see the calcification of a falx cerebri, and then bifid ribs, and or first degree relative with the same syndrome. And then the minor criteria, it's quite wide and so on. It's almost all type of criteria which you'll see in a number of other syndromes. So at that. So you see a radiograph, so yeah, this is no question that if you do histology, you're going to expect, and you have to do histology of multiple OKCs. They were OKCs. In this patient. So multiple BCCs in this younger guy, you can see on the skin, multiple of that, calcification of the falx cerebri, palmar pits that's present, and hypertelorism and frontal bossing. So all the features. This is one of the well-known patients we had in the hospital with this syndrome. You all know about the patch mutation and sonic hedgehog. I love it when the names come out of sonic hedgehog. And I can just imagine seeing that ponytails doing in a research lab, finding this and say, what are we going to call that? No, let's call it a sonic hedgehog. I think it's great. With smooth and the role of that. And this was one of the unfortunate chapters in our field was in the Blue Book in 2005. And that happens when you get surgeons involved in doing pathology classifications. Peter Reichert was a guy, I know him fairly well, a German guy. He's a good friend with Hans Peter Philipsen. But he's got no idea surgeon. You can't get a surgeon to Google things a neoplasm. Call it a keratocystic odontogenic tumor. I can be quite honest, I refused in our department for us to call that name. Even when it came out, said that's one thing where it is now not a democracy anymore. It is an autocracy. No one, doesn't matter what your personal belief is, but in my department, that name is not going out. So that never happened, fortunately. So if you look at what is the reasons behind it, there were some mutations of a patch gene in OKCs, etc. And it was linked to the basal cell. We know it is to the basal cell Nevo syndrome. You find that mutation in almost all families with this basal cell Nevo or the golden gold syndrome. But we find it is really present in a number of cases as well. So you cannot, when you have one mutation, they call it a neoplasm. So it is definitely not a neoplasm. Let me say a few words on it, and I think we're busy a paper on that. We have such a consortium of odontogenic tumors from the WHO. We're busy writing a paper on this. The concept of a neoplasm, that's based back to your basic anatomical pathology. It's a clinical concept. What is a neoplasm? A neoplasm means uncontrolled growth. So you have a lesion, doesn't matter what you're going to do, it's going to get bigger and bigger, bigger. It has lost control. That is a clinical term. And what happens with the new advances in molecular work and so on, we found the mutation, and so now it is a mutation, therefore it's a neoplasm. That's nonsense. It cannot be. If you look at cases, for example, what is the classical one? Simple bone cysts. What is a lesion that disappears? Is it a nodular? Anyway, some lesions that this typically regress, that is related to UPS6 mutations and so on. If a lesion that's regress spontaneously with a mutation, it's not a neoplasm. Fibrous dysplasia, it's not a neoplasm. It's linked to a genus 1 gene. It's not a mutation. So you can call it's a mutational driven lesion, but don't equate that to being a neoplasm, because that's wrong. Neoplasm is a clinical term, because that lesion is going to get bigger irrespective of what you do. So it doesn't fulfill that. The fact that the lesion recurs doesn't make a neoplasm. Any tumor, and you have to remember that, any malignancy that recurs, all it means, the surgeon didn't take everything out. That's all it means. It's not. It may be other reasons, but for any lesion to recur means it wasn't taken out during resection. End of story. Nothing else. If you look in the oral cancer cavity and so on, if a lesion recurs, it may be a new primary and so on, but if it recurs, it wasn't removed. End of story. So to say that OKCs recur a lot, you get a new surgeon. That is the reason why the lesion recurred, not because of the behavior of the entity. As I said, there are many non-neoplastic conditions with mutations linked to cell proliferation, and not all of them are neoplasms and so on. What is important, if you look at we call it sporadic OKCs, the patient with just one, quite a significant number of them have also the patch mutation, but similar to the basiloid Nevo syndrome. So just based on that, it means it's one of those things, but you cannot call it a neoplasm. We did a study a few years ago. It was published last year, where we did, and it's a very nice tool for us as histopathologists. It's the OncoScan, not OncoScan, yeah, I think it's OncoScan, from Informatics, where you can really do genomic evaluation of lesions from formalin-embedded tissue. Quite accurate, it's fairly expensive. And we've looked at a few cases of known syndromic patients and sporadic. All of them, I think 4 cases each, had the patch mutations, etc. Look, if you want to do a career in this field, do a pathology background, but go into bioinformatics. That is one tip that I can give you guys. If you look for any data on genetic evaluation and so on, you can do so many PhDs without doing anything yourself. Just look at the data, GenBank and so on, where they are published. And the data there is mind-boggling. You really need a knowledgeable guy who is in that field to extract that data for you. It may be easier now with KI coming in, but the amount of data available, even if you look at this, you get the information back. It's mind-boggling to look at all that. So just to say, yes, we've done our little bit as well, but no difference between OKCs and the sporadic ones. And then it's now correctly by Paul as well, and the WHO is classified separately, is for orthokeratinized odontogenic cyst, nothing to do with OKC, except that it's forming keratin. But you typically have the orthokeratin, and how do you easily know it? It is associated with a nice prominent granular cell layer. Just diagnose it correctly, and it's fine. Clinical presentation, etc., exactly the same as OKC. Right, these are nose stripe anemone fish. Normally, anemones are poisonous to other fish, but they've got a special coating, so they hide behind these anemones. Beautiful little fishes. Right, dentidious cyst, or if you want to call it a follicular cyst. We all know what it is. It encloses the crown of an unerupted tooth, and you look at the follicle, the pathogenesis is enlarged. The histology of a dentidious cyst and the dilated follicle, exactly the same. So you need to have a radiograph. My cutoff point is 4 millimeters, a radiolucency to call it a dentidious cyst, otherwise it will be a follicular hyperplasia. Again, the same story. Surgeon's going to get more money if it is a dentidious cyst compared to a dilated follicle. And if you look again with data from Paul's new book, from the 8 down to the 1, so obviously most in the mandibular 8, as we know, and the second most your maxillary canines associated with impacted teeth, forming dentidious cysts. And you know that as well, the radiological appearance of dentidious cysts can be quite varying. And it's well documented, nothing has changed. The key is the cyst is attached to the crown cementum junction, to that area, but radiologically it may be compressed where it looks like it's from the whole area, but trust me, it's linked, it's attached to the crown cementum area. Can be quite large as well. The typical case, and there's also, I think, unfortunately, too much emphasis placed on this. You're looking at this, your differential may be a dentidious cyst, unicystic ameloblastoma, maybe OKC, and they'll tell you, look, there is root resorption, therefore it's most likely a dentidious cyst compared to unicystic ameloblastoma. Yeah, it may be, but I found that it's not always the case. These cases, cysts don't read books. They don't know how to behave. So it may be, but I don't put a lot of emphasis on that. But you can get, this was a dentidious cyst, obviously with displacement of an impacted 8, can be quite large as well. This is the one cyst where you have to insist on getting a radiograph. I tell you now, because I've seen cases where it was fortunately stopped, but could have had massive implications. Productive histology, you have an epithelium resembling reduced enamel epithelium, and you will be lucky to find it so nice. It's very often difficult to find this intact epithelium in a dentidious cyst. There as well, some almost change to non-specific, but start looking at this. The key in these cysts are this almost loose myxoid tissue, because if you look at the back to odontogenesis, that is what it looks like in the tooth follicle, that material. This is more likely that you see almost the interrupted areas, and you have to search. You can have a few cyst walls and only this small fragment consisting of lining epithelium. And then it may also be non-specific, almost stratified squamous type of epithelium without that. Some ciliated cells may be present, and some mucus cells as well. Mucus cells, you can find it in any odontogenic cyst. Don't see mucus cells make it a glandular cyst. We'll come to that. And then your problems, when you have inflammation, as you quite often has in a dentidious cyst, The same as with OKC, the nature of the lining changes, and it's difficult, apologies, to diagnose this. But then be on the lookout. You have in a dentigerous cyst, typically these islands of inactive odontogenic epithelium. It may be in strands, it may be round islands, sometimes with mineralized tissue. The only abnormality here is the dense nature of a cyst wall. It's typically more myxomatous, but you have these islands. This is more of a typical feature. You have this almost myxomatous stroma, cyst wall, with these odontogenic islands. If I only show you this, and I ask, what is it? And you tell me it's an odontogenic myxoma, I cannot say you're wrong, because this is what odontogenic myxomas looks like. Maybe a little bit too much odontogenic epithelium, but you can get it. Why is it important? And this is what happened, especially if the biopsies are done by anatomical pathologists who do not know. So you get a surgeon, he's not keen on writing, he said lesion, corner of mandible, angle of mandible, and submit this in. He gets this, I say, okay, this is myxoma, this is what it looks like. But if you get this, you call it a myxoma with that lesion. And I say, okay, let's excise it. But this is the case, this is a myxoma, the typical features, expansion, subbubble appearance, and you can see the clinical photos here. And that should be prevented. And I've seen cases where, fortunately from a parent's side, they ask for a second opinion because they want to resect part of a jaw for a dentigerous cyst. Get a radiograph. And you may think it is logic and common sense, but the reality out there in a population, most of these cases will be submitted to anatomical pathologists, and they haven't got the faintest clue what's going on. And so please make certain that you don't make that mistake or is forced on that mistake. Right, the eruption cyst, that's basically a follicular or dentigerous cyst in soft tissue. We've seen them. So it was typically where the primary tooth was extracted earlier. There's fibrosis too lot. The tooth erupt, but the soft tissue is more fibrotic. It's outside bone, but you get that follicle expansion, typically filled with blood and so on with these clinical features. That as well. That's a typical classical features. Simplest incision way, open it up and it will erupt. And the body is wonderful, and the gingival will form nicely against the erupting teeth as well. Semicircle angelfish, beautiful fish for me. Lateral periodontal cyst. Again, you need a radiograph. Just a description by the surgeon, because you have here a cystic lesion in the gingiva. If you look at the histology, you can call it a gingival cyst of adult or a lateral periodontal cyst. One is in bone, the other one not. So you need a radiograph to find this lesion. In your differential diagnosis in lesions like that will be lateral periodontal cyst, always a lateral radiculous cyst, because your tooth do have lateral canals, and if that tooth is non-vital, it may be a radiculous cyst on the lateral aspect. And quite often we can find OKCs in that location as well. This guy too, lateral periodontal cysts. And this is the histology, typically epithelium, and then we have this classical epithelial whorls that we find, you see there. Same with a gingival cyst of infants are present. These epithelial whorls quite beautifully. And then you get the two entities, and don't confuse them. You've got a lateral periodontal cyst, which is a single cystic lesion. And then you get what's called a botroid odontogenic cyst and a multicystic lateral periodontal cyst. The multicystic lateral periodontal cyst has a unilocular appearance radiologically, but on histology, it looks like this. Whereas a botroid, you can only diagnose it if you have that multilocularity on a radiograph, and it looks like this. So the histology between a botroid and a multicystic lateral periodontal is exactly the same. The distinction is on radiograph. Sometimes people confuse these concepts, but it's fairly straightforward. So again, a radiograph is key to that, no implication for the patient. So this may be a multicystic lateral periodontal or a botroid. I had a nice discussion with Paul Specht when he wrote his book on this as well. Some snappers. Right. Sorry, is there a question? Okay. Glandular odontogenic cyst. Personally, I think it's overdiagnosed. It's my personal opinion. I'll tell you why. Radiologically, spectrum. It kind of looks like anything. If you have, for example, you think of it's the same almost as a granular cell tumor of bone. It can have look multilocular, unilocular, or like this. If you look at this and I tell you, okay, it can be a mieloblastoma, may even be an OKC, glandular always. You can think of a whole number of things. If you have to stretch it, then it's most likely not a glandular odontogenic cyst. There have been publications you need 9, I don't like 9 features and all that. I don't like it. For me, is you need to see intraepithelial glandular structures, as the name implies. Not cystic lesions, glandular structures like that, some of them lined with mucus. I don't care about the mucus cells on the surface. As I say, you can get it in any cyst. But this is the key. These glandular structures is, for me, one very important. You can have this thickening. Clearly, these glandular structures within the epithelium. Your superficial layer can be ciliated. We did EM that was optimally fixed. Sometimes we had the opportunity, every cyst was put in glutaraldehyde, a piece of that, and we had, I think, 15 glandular odontogenic cysts optimally fixed for electron microscopy. We looked at that, and that's actually apoptotic cells at the surface of a glandular. There as well, very nice example. And then another important feature are these papillary processes that you see. If you look at the sites for that, they'll tell you, look, the anterior maxilla is a common site for glandular. I don't think so. I think they are all nasopalatine duct cysts, which has been called glandular odontogenic cysts. So I don't believe a number of those cases, but that's my personal view. Your big thing is obviously to distinguish it from an intraosseous mucoepidermoid carcinoma, which is a unique type of, it's not a salivary gland, it's an odontogenic carcinoma, mucoepidermoid. Like all mucoepidermoids can be cystic, but typically you'll have more of a solid proliferating areas. Even if it is cystic, hopefully you'll find some of that. And if you want to do, you can, if you have access, you can do the fish for MAML2. We know not all mucoepidermoids on salivary gland are MAML2 positive, but the ones that have been done intrabone, the intraosseous one, have shown to be positive for MAML2. You find the fish signals there, while it's not the case in a glandular odontogenic cyst. Potato bass, one of the cases. COC. And this is another one of 2005 unfortunate changes where they call it a neoplastic tumor of a cystic lesion. It's crazy. Call it then a calcifying cystic odontogenic tumor. Another one I refuse that we call it like that. So I think now this sense have prevailed. I'll go through what it has been called. So you have a cyst. It's easy to remember. You have got a COC cyst, and you've got a solid variant, the dentinogenic ghost cell tumor, no cystic component. It's a solid tumor. And then you have got the malignant component. So treatment is simple enucleation. If you see calcifications, because there has to be calcifications as the name implies, calcifying odontogenic cyst or the Golden cyst, if you're fortunate, you may see some of the calcifications on a radiograph. It's not often there, as in many cases. you really need a lot of calcifications to see it on a radiograph. So if you don't see anything, don't exclude the possibility of a COC. Quite nice. This is most likely COEC with an odontoma. There's a lot of calcifications just for what you see in epithelium. As I said, it can be quite large. If you look closely, you'll see some calcifications in this cystic lesion there as well. And this is the typical histology. Basically epithelium, it looks like ameloblastoma, all the typical features of Vickers and Gordon. And then you have your ghost cells and you have your intraepithelial calcifications. Very nicely demonstrated there as well. And there. Ghost cells, and why it's a ghost cell? Because it's a large cell without a nucleus. Where a nucleus is supposed to be just an empty hole. And then these calcifications. Again, no, that's ghost cells. You can find ghost cells in any tumor, any odontogenic tumor, anyone, from an odontoma to anything. So it's one of those things, it is an opinion, when is it too much, and so on. And I don't like cutoffs, percentages, because it's difficult to evaluate. It's not reproducible. So it's the image that you can get, the impression that you feel. But in a cyst lining, that is, if you see ghost cells, that's basically it. It is a COC. And as I say, the rest of the epithelium can look that, and you find these almost dentinoid or basement membrane substance as well. And some of them have a typical feature as well. The same if you get a unicystic ameloblastoma. Not the whole lining will be typical ameloblastoma. You can have areas that is classical stratified squamous. So you have to be on the lookout to find the typical areas. And then you find this as well. And large areas of dentine as well. That you see in the wall. So Finn Praetorius, he in 81, and that was fine. That was the time when I was studying, and it made sense to me. He had a cystic type, we call it, that may be simple or then associated with odontoma, and then associated with ameloblastoma in the cyst wall, and then with solid tumor. And when people start to do research, and we need to publish that, and this was done in 98, it was crazy. I'm not even go through it. The registrars will probably know that, but you add more detail and so on. And that is a tendency even for odontogenic tumors. And I think that's one good thing on the WHO is to come back to basic, to simplify it. To have one case and add that case to a classification makes no sense at all, especially if it makes has no biological influence. And then our WHO friends of 2005, Peter Reichert's a surgeon. Hans-Peter Philipson is also a pathologist, and is very, very good oral pathologist. He's published a lot of good stuff. He was in Hong Kong, and he was in Germany. And they came out with this. So it's a non-neoplastic 4 variants of the simple cystic one. And then you have a neoplastic cystic lesion with all that. Now, I can tell you, it is not possible to sit under a microscope with a slide and say this is where it is. It's nonsense. So we refuse to do that as well. And then even a malignant one, call it a cystic subtype, ridiculous, and a solid subtype. And then Paul Specht and Mervyn Scheer, that is what they've adapted. And this makes sense. So you have a COC, your classical Gordon cyst. And it can be associated with any odontogenic tumor. Most common will be odontomas. Second commonly is ameloblastomas. And the implication is if you have a COC with an ameloblastoma in the wall, you treat it as an ameloblastoma, not as a COC. So it can be with any one of the tumors. So that's fine. Just know that. So COC with that. And when you have a solid lesion, they call it, that time was before they call it a calcifying cystic odontogenic tumors. No, call it a COC. And then the solid version, as we know, is a dentinogenic ghost cell tumor, and then the ghost cell odontogenic carcinoma, the malignant variant, which has typical features like any malignancy odontogenic. You need to have atypical mitosis. You want to have necrosis. Be careful when you look at any malignant odontogenic tumor and you want to call it with increase in mitosis, but they are all normal. be very careful. I think there's a number of groups working on that concept of ameloblastomas, the spectrum, and I think hopefully it will be cleared soon. Right, now to the non-odontogenic group, nothing new about nasopalatine ductus. Nothing has changed. It remains there. It's from remnants of your nasopalatine canal. Very, very common as a non-odontogenic lesion. And to your slightly older group. It can be quite large. It can be quite big. Often with palatal as well as anterior expansion with swelling. Quite large with heart-shaped radiolucency. Again, always you need to get the vitality of his teeth to distinguish it from a radicular cyst. Anterior maxillary teeth, a most common area for radicular cysts. Again, typically there, that is what it is, nasopalatine duct cyst, and on an occlusal radiograph this appearance. Reconstruction, quite large. And then, if you're fortunate, if it is not inflamed, quite often they are, as they are ulcerated sometimes, it's lined by respiratory type epithelium, maybe over to stratified squamous. And then typically in the wall, you find these prominent neurovascular elements. Nothing to do with the cyst, it is from an anatomical area where you have that neurovascular elements. Again, with typical respiratory epithelium, there's more a double-layered cuboidal. Again, the neurovascular elements and the neurovascular elements. Karl Rockart. Now, nasolabial cyst. You need to have a radiograph to show that there is nothing going on. So it's a soft tissue swelling. It's not involved in bone. It's remnants from your nasolabial duct, which is quite well developed in animals, etc. So it's a slowly growing lesion that you find. No bone involvement. You can see the swelling there. Lined again by respiratory type epithelium, but as I say, the key is no bony involvement. These are called nudibranchs, so it's actually mollusks or snails without a shell. So they are beautiful, quite a whole spectrum of them, and these are the breathing apparatus and so on. But you find there are two of them and they are busy mating. Simple bone cyst, yeah, as you all know, it's the surgeon will tell you, look, couldn't find any epithelium, was an open cavity, etc. Different names, traumatic, hemorrhagic, idiopathic, and so on. And simple treatment, you just, this position is fine, you induce bleeding, and that will lead to organization of hematoma with new bone formation. Typically, you get scalloping of the radiolucency between the teeth. That's the classical appearance of that. You will not typically find expansion. Because if you look at that, you sometimes have the radiologic or histologically decide between a simple bone cyst and an aneurysmal bone cyst. And you can find simple bone cysts also linked to other conditions, like a florid cemento-osseous dysplasia, first described by Melrose in 1964. But this is samples of a simple bone cyst. Histology is just like you can maybe do a 31, CD31 if you want to look for endothelium cells, but they are not there. You may find new bone formation in the wall, but you find these cystic cavities lined by compressed fibrous tissue. Some reactive bone in the depth as well. Some fibrin maybe on a compressed surface. And this is just a case of a florid cemento-osseous dysplasia with cystic changes and so on. Be on the lookout for that. For if you have a florid with that, with cystic lesions. And then as you, this is a florid osseous, the histology of that. To confirm that. And then aneurysmal bone cysts, lots have been said about it. You get basically the two variants. The primary one, which is on its own, or the secondary lesion linked to a pre-existing lesion, typically fibro-osseous. I think it's wrong. I don't think those secondary are really true aneurysmal bone cysts. You can call it aneurysmal bone cyst-like because they are not, they don't have USB6 mutation. They behave differently, And I think there needs to be some clarification still on the nomenclature on what you call that. But aneurysmal bone cyst, you will see multilocal, it will expand. It will not be like a simple bone cyst. It almost have that blowout feature radiologically of that. So as you see, very multilocal expansion, and that will be an ABC. Well, not that rare in the oral cavity. And same way, you may have more areas of hemorrhage, osteoclast like giant cells in the cyst wall associated with the cystic lining. Latent bone cyst, just for completeness sakes, it's not really cyst, it's just an abnormality. We have an indentation below the inferior alveolar canal. And if you get a biopsy done, it will be filled with salivary gland tissue because it's just the indentation and the submandibular gland tissue will be in there. So nothing specific. It's just a radiological diagnosis, nothing to be done on it. Typical features. So in summary, to end up, I think this is important. That is basically the take-home. Never make a definitive. Look, you can make a provisional diagnosis, but the definitive means that is it. If that patient has that lesion, what you say he or she has. And you have to be certain that you have all the information at hand, available, in order to make a definitive diagnosis. You owe it to that patient. Patients don't know. They're waiting for a paper, and now they have this disease. And you have to make certain that you made the right call, and you can only make the right call if you have all the information available. So always check on the radiographs. Look at for specifically yourself. If you have access to that, cone beam CT is important. Just a word on cone beam CTs. If you look at the pan, something we grew up with, it is a multi-layer area with panoramic view and so on. A cone beam is a very thin slice of an area. And it's, you get the idea that on a cone beam, on that slice, it looks quite often it looks more infiltrative or poorly circumscribed as when you do a pan. Just remember that. Look at everything, reconstruct a pan for yourself from a cone beam to get back to the traditional views, but very careful to interpret a slice of a cone beam for circumscription. And always embed all material. You get the tissue and you get hard tissue. I'm not talking about the root, tip and so on. If you get hard tissue that is submitted as a specimen and you see a lot of soft tissue, don't leave that hard tissue for reserve. No, you miss big information. Even if it takes a day or two longer, submit that soft tissue but decal that hard tissue so that you can look at it. It's a mistake that I see so often. People say, no, that's fine. There's hard tissue, that is a reserve. The only hard tissue that you put through as a reserve is a tooth. Nothing else. It has to be put through. That's very important. And don't be pressurized to support conservative treatment. They may say, okay, look, I'm not going to be aggressive and so on. We see it so often in a case of ameloblastomas in a young child. You feel terrible. You always have to think, if this was your child, what would you call this? What advice will you do? It's fine to say, okay, there's ameloblastoma, let's marsupilate it. But fortunately, I've been around many, many years, and I've seen what happened to those cases of ameloblastomas that get marsupilate. I can even show you radiographic evidence. Look at the new bone formation. Means nothing. A few years later on, there's soft tissue involvement and you get huge resections. And if it is in the maxilla, you have got huge problems. People have died from ameloblastomas not completely removed. So yes, you like to think, okay, let's err on the safe side of caution. It is very difficult. It's not as straightforward. So if you are in a vat, get a consultation, get the clinician, get everybody involved, get colleagues involved to make the call. It's unfortunate that the patient may have that disorder and disease, but you're not helping them to suggest conservative treatment and so on. You're not doing them a favor. It's a very difficult call to make, but that's why we are studying and all do all the hard work in order to make that call. Right, Pablo, thank you very much. That is it. I don't know if there are any questions. You can
Thank you, Willie. I have a few comments. Great talk, as usual. Okay, I'm sure the students enjoy a lot this overview about odontogenic cysts during this hour. And we don't have any beneficial reporting as periapical cyst or granuloma here in Brazil, but we do the same. If you see something compatible with radicular cyst, with inflammation, thick capsule, and the X-rays, when you put all together, you can report it as compatible with periapical cyst. So we do the same, but I think it's important because sometimes we don't receive all the material because the curettage, it's incomplete. So you saw only inflammation and the thick capsule, but yeah, you can report it as compatible with periapical cyst. You showed that the calcified odontogenic cyst can occur with any odontogenic tumor. And we saw a very interesting case that Andrea Caroli sent to us that was a ameloblastic fibroma, a huge ameloblastic fibroma with cock areas. So it's quite interesting because we can find this kind of cock finds in odontogenic tumors. And the odontogenic keratocyst, that budding that you showed us. Yes, I sent a message to Narciso because Narciso sent a case for us 1 week ago, and Anna reminded me that, oh, there was areas with budding. Let's talk to Narciso. Narciso said, oh, I think the patient has no syndrome at all, but I will have a look at again. So yeah, thank you very much for this kind of information, for sharing your knowledge and your experience with us. Thank you very much.
Thank you.
Questions? Any more?
Good morning, Professor. Very easy following and eloquent conference. I have a question that might sound silly, so I apologize in advance. You have expressed some of your opinions about the Blue Book very clearly, but what's your personal take on the suggested possibility of malignant transformation on some specific cyst?
No, absolutely. Look, I like the new Blue Book. I wrote a few chapters, so I have to like it. The previous one as well. It is just for 2005, which was ridiculous. Yes, absolutely. And the cyst and we've got nice cases of that. Is OKC, where you can have other cysts as well, but it's very difficult when you look at the material to say, look, it was a dentigerous malignant or that. OKC, you can do it. And we've got nice cases which was typically an OKC and which later on progressed to an odontogenic carcinoma. So for me, for all practically, it's basically only the OKC, but definitely there are well-documented cases, can happen. I'm excluding the unicystic ameloblastomas and all that, just from the other cystic lesions. Yeah, sure. But please, I'm not an opponent of the Blue Book. It's only the 2005.
Thank you.
Alan, questions?
No, he's not allowed to.
Yeah, he's not. Yeah. No. You must use the microphone.
Willie, thank you so much once again for coming. You're such an important friend and collaborator of the group that we cannot thank you enough. One question about this lack of surgical vision, globally speaking, but I have the impression that Africa and Brazil have several common pathways, historical pathways, and we have a lot of poverty and undertraining. So my question is about your personal and professional view throughout these 40 years of career. How do you think we can change the training of surgeons in general to understand the odontogenic cysts, their behavior, how we can change the game in this sense, thinking of our patients? Thank you so much.
Yeah, thanks. That's a very important question, Alan. What we've introduced now as part of that, the maxillofacial and oral surgeons in training at Pretoria, they rotate for 3 months in our department, full-time. They work there, they put through, they may be on call, but they nothing to do in their department. The same with our oral medicine specialists. 3 months in our department. So they come in, they put through, they go through this histology, work it out, we discuss that. And then you can see around the microscope the difficulty in making a call without the clinical information. And that has changed a lot, Alan, for their view. That's why, and we don't look in our hospital at any case without the radiograph. I'm actually anal about it. So if I didn't take, the registrar has to come up and explain to me why I didn't take a photograph. And I will know about it. So they've got cell phones, they must take a photo. They must do it. So, and you learn, you teach them there. So, but that has to be in everybody. So not all the other institutions have that. So it is a problem. And some of them in private especially, they'll feel, you think as a pathologist, but if I'm going to insist now, he's going to send his work to somebody else. So be it. They must send their work because you're on a specialist level and they want the best for their patient. And that is to refer their work to what they think is the best pathologist and so on. If they don't do that, I won't refer people to him, and I don't think that's a good surgeon or an oral medicine guy. They must be really inclined to do the best for their patients, and that means supplying the best information. It's a long way, and it's not only us, the Americans and other, the British and so on, similar problems, getting clinical information. There are even clinicians who say, look, why do I have to send this stuff to a pathologist? It may influence his or her opinion. Of course it should, but they, surgeons, I hope there are not any surgeons here.
There are a lot of surgeons here. Yeah.
But you know the story in an elevator. You know the doors close. How will a surgeon, the door closes, how does it stop it? He puts his head in and he said, I'm working with my hands. Sorry, surgeons.
Okay. We received a question from Leticia Ferreira from Dallas. Wonderful lecture, Professor Willie. I did not understand the difference you mentioned between a multilocular lateral periodontal cyst and a bothroid odontogenic cyst. Okay. According to the WHO, bothroid odontogenic cyst is the multicystic variant of lateral periodontal cyst.
No, she's correct. It is a variant of lateral periodontal. As I say, histologically you see the multiple cysts, but on a radiograph, you have that area where the lateral periodontal was, but it's multicystic. You see multicystic lesions, and that's why it's called bothroid, like a bunch of grapes. Whereas if you have a single radiolucency, and under the microscope you see multiple cysts, you cannot call it bothroid because bothroid is the clinical radiological features, but it has to be multicystic. Then you call it a multicystic lateral periodontal because it's radiologically radiolucent. Did she watch on YouTube?
Yes,
okay.
She's been watching on YouTube. And
hi, Leticia.
Yeah, hi, Leticia. And I wrote this chapter for a WHO book as well, and I used X-ray from Willie showing this multilocular feature of bothroid odontogenic cyst. So you are right, but he insists that you have to find the multilocularity on X-ray to sign out as a bothroid odontogenic cyst.
Correct.
If you don't find it, you have to report it as a lateral periodontal cyst.
Or multicystic.
It is or multicystic, but it's the same lesion. Exactly. You are right. But yeah. Okay. Questions? Marcelo? No? The postgraduate students. Okay, Kaique, please. Come here, please.
Thank you, Professor Willie, for your presentation. Recently, we have a diagnosis of OCC case here in our service. So at the first moment, we don't thought about this diagnosis because the radiograph aspect, we see a few calcifications aspects, and the lesion was not uninuclear aspect, and we have an aggressive bone expansion, and another aspect that not relate to this diagnosis. So you saw your presentation, even we see few calcifications, we need to consider the diagnosis. So I would like to know if what else more radiograph feature that we need to know about the diagnosis of OSC and how we can differentiate from other tumors like ameloblastomas.
Okay, so you're talking about odontogenic keratocyst. Is that okay? Okay, C.
Calcified odontogenic.
COC. So,
COC.
Okay, so
Calcified Garland cyst.
So the question was for calcifications where? Because you expect to find calcifications. No calcifications.
He saw a case in Oral Centro, in our oral diagnostic clinic, and that looked like an ameloblastoma radiologically, but it was a COC. So in your experience, do you think this is common or?
If it looked like a
It's rare.
ameloblastoma, was it multicystic or so on, multilocular?
It era multilocular. Multilocular.
And the COC, it wasn't a solid variant. It was a cyst. It wasn't the dentogenic cell tumor. It wasn't solid.
No, it wasn't.
It was a cyst. Yeah. Look, if I understand it, so the question is the lack of calcifications histologically. Is that correct? That you want to know? Or
pouquinho de calcificação tinha ou tinha não tinha? Few calcifications.
that's fine.
Not.
That's
Yeah.
fine. It varies. It doesn't have. That's why I say it doesn't have to be where you have ghost cells. You find calcifications, and yes, it's true. You can sometimes, with a normal COC, the colon cyst, really search to find calcifications. They can be really scarce or rare in the lesion. That's fine.
Okay, last question.
Thanks.
For GOCs, I
For
agree that
glandular,
there's,
yeah?
yes, there's no specific diagnostic criteria for GOCs. It's a constellation of microscopic features that we make that diagnosis. What is your threshold for intraosseous MECs? Do you like to see the solid epithelial proliferation? Because one of the microscopic features for GOCs is multiple cystic compartments within
Yeah.
the capsule.
Very, very good question, Annalisa. So for the intraosseous mucoep, I think is that apart from a radiograph, which may be unilocular and so on, is you tend to see tumor islands invading between lamellar bone that you find in the and you find more solid areas. It's not predominantly your or so-called it the low-grade cystic mucoep. Typically, you'll find more cases with solid areas in the intraosseous mucoep. But it can really be, I've seen cases where it's really difficult to make the distinction if you haven't got access to MALMAL2. And if it is MALMAL2 positive, typically if you leave a specimen was decalcified because it's interbony and then you have problems with a fish, you can try it. If it's absent, you cannot be dogmatic that it's not a mucoep. So it can be difficult.
And we need more cases in the literature to make strong conclusions about the right treatment for intraosseous MAC because it's so rare. Maybe only few cases reported with the translocation show MAMO2. So it's my personal opinion, of course.
Yeah.
Yeah.
Yeah, the thing is, it's a malignancy. So, as with all cases, do a resection, get it out of clear margins.
Yeah. Okay, thank you very, very much for your presentation. Okay. Pessoal, se vocês quiserem tomar um café, tá? Ele vai ficar disponível ali. Não vai ter um coffee break agora de manhã. Vocês pegam bolo, pão de queijo. A Cibele organizou. Vocês podem ir subindo, pegando lá e comendo, tá, pessoal? Okay, our second talk this morning. I'd like to invite Dr. Cesar Migliorati. Dr. Cesar is a very good friend from our postgraduate program too. He's been working with us for many years. He received our students at the University of Florida. So it's a huge pleasure to have you here, Cesar. And he's going to talk about osteonecrosis in the jaws, 20 years and counting. So I'm sure we are going to enjoy this talk as usual. Cesar? Thank you.
Obrigado. Good morning, everyone. Although I'm Brazilian, I was asked to speak in English. My English is very easy to understand because it's kind of macaronic. It's mixed with Portuguese, Italian. So before I start, I would like to thank the invitation. It was not easy to get up at 4:30 in the morning, but here we are. I am very happy to be here collaborating with this group who we have been friends with for many, many years. And one thing that I want to say before I start is apologize for my voice. I'm coming out of a bout of flu, and I still have some cough and so on, that I hope things will flow. Many of you have seen and heard me talk about this because we were one of the first people to report this in the literature. So this was first reported by us in 2003 in the Journal of Clinical Oncology. And then Dr. Marks in Miami and Dr. Ruggiero in the Jewish Hospital in New York came with all the cases that started this process. So I will try to do just a brief overview of our experience with this complication in the oral cavity, and mostly update you on what is current. When there are a couple of things that changed. So one paradigm that changed is that we, in the beginning, mentioned or recommended no surgical approach. Today, we know that this paradigm changed, and many people treat immediately osteonecrosis of the jaw with surgery. Many medications came about that have been reported to cause this complication. So my idea today is to just give you a brief overview of what we have seen in the past 21, 22 years. I am at the University of Florida in Gainesville. I'm a professor in the Department of Oral and Maxillofacial Diagnostic Sciences in the Division of Oral Medicine. So oral medicine is my specialty. Here we call it stomatology, but I'm used to saying oral medicine, so forgive me. So today I just want to do an informal overview of this complication that, thank God, does not affect too many people on the medications that we're going to discuss. But when it affects people, it can change drastically the quality of life. And I'm going to start with the case. So this is a case that I saw in my clinic. The patient was referred to us for evaluation. It was a breast cancer patient, metastatic. And because of that, the patient was being maintained on IV bisphosphonates. And there was a sudden onset of clinical signs and symptoms that appear to be coming from either the tooth or the periodontium. And this is how many of these cases start. So the patient feels that, goes to the dentist. And the dentist, of course, is going to do what they do. They're going to check the vitality of the tooth. They're going to check for pocket depths, bleeding, and all of that. So that was all done. That was the tooth number 18, which is the second molar on the left side of the mandible. And the tooth was broken. It had to be extracted previously because it was hopeless. So tooth number 18 was extracted, but the healing was very complicated. Took a long time to start healing with the mucosa covering the area. And the patient said, but the pain is not just here. I have pain in different areas. Everything seems to be radiating to other parts of my mouth. So the dentist treated what seemed to be a routine problem. Okay, but it didn't resolve. The symptoms got worse, and the patient then was referred to us. With this history, you must include in your diagnosis osteonecrosis of the jaw. Basically because the patient has cancer metastatic to the skeleton and is on IV bisphosphonates. Okay, so that must be included, which our colleagues unfortunately don't do. They treat the patient as having just a routine dental problem, and that only gets things complicated. So let's see. When I saw the patient in the beginning, this is the area where 18 was extracted. The bone was very irregular, and there was not complete healing. And there was also involvement of tooth number 19. And this is a feature that we see, especially in patients on bisphosphonates, is this sclerosis around the lamina dura, that until today we do not know the meaning of this, but is a finding in patients taking bisphosphonates. So the dentist then did the root canal on tooth number 19, put a crown, but the process continued. So pain, symptoms, medication. So the patient was seen here. This is X-ray in 2006. When the patient came to us, that was the situation. We could not find any area of exposed necrotic bone. There was no fistula, nothing. But we continue to follow the patient. So this is now in May of 2007. There was still sclerosis. Root canal was done, was improving here, but the patient was still in pain. Until we continue to follow, 11 months after the endodontic treatment was done, we had the exposed bone. Okay, so this is a typical case that we can avoid, put the patient on suffering because we did not make the correct diagnosis from the beginning. Okay, so this is one, that's why I wanted to show you this from the start. And for those of you who see patients with breast cancer and metastasis, there are new ways of these people being treated and maintained. And a lot of that involves the use of bisphosphonates, which puts the patient at risk for osteonecrosis. So MASK, our group at MASK, just a paper by the Mass Journal, Supportive Care in Cancer, that talks about the new ways of adjuvant bone-modified agents in primary breast cancer patients. And we talk about the ways to prevent the medication-related ONJ. So this is going to be published pretty soon. So here the problem starts for me, which is only an academic discussion, but definition is very important. And of course, there are different groups who want to impose their definition. The two main groups are the Americans, from the American Association of Oral and Maxillofacial Surgeons, and the Italians. And because I'm Cesar Migliorati, I'm Italian, I'm in the middle of this controversy. And so when the Americans publish a definition, the Italians call me and say, we don't agree with that. I said, well, then publish what you want to do. But you have to support us. Well, I have to support my patients. That's what I do. But it's a tremendous discussion. Who has the most correct definition? So I put this here for you guys, and each group has a different view. But definition is important because it helps us to diagnose the problem. Okay. And so how do I suspect the patient has osteonecrosis? When they come like this with an area of exposed necrotic bone, there is no history of radiation therapy. The next thing that could cause this is a medication. I have not seen many cases with viral infection. In cases of advanced HIV infection and AIDS, we can have osteonecrosis of the periodontum, and that is associated with herpetic infection. And so this is how I suspect. The patient has either cancer metastatic to bones or osteoporosis or any other disease that affects bone and is treated with an anti-resorptive, with an anti-angiogenic, or nowadays with some of the biologicals. The symptoms could be pain, swelling, infection, numbness, and halitosis. There will be either exposed necrotic bone, as you see here, or necrotic bone that can be probed through a fistula. So there is a fistula, only you can go in with your explorer and you can touch the bone, there is no pain. So that tells you that that bone is altered. Imaging may be suggestive because you see a lot of osteosclerosis, and then the patient has no history of radiation or metastatic disease to the jaws. And this is another question. How do we know that there is no metastasis here? And we're beginning to think that if you're in doubt, you may need to take a biopsy and then confirm if it's metastatic or not, because that may affect the way the patient is going to be treated for the cancer. So an early diagnosis, what the Americans call the stage 1. This is a patient on Zomita for metastatic breast cancer, and she went to the dentist because her attachment prosthesis was no longer fitting. Patient couldn't fit the prosthesis, but she had this area here of exposed necrotic bone. So very early stage, stage 1. This is a more common situation where the patient has a dental problem, goes to the dentist, the tooth is hopeless, the dent makes the extraction, and there is no healing. So you have a granulation tissue, you have exposed alveolar bone that is necrotic, and in the radiograph you see what we call the phantom alveolus, which shows us there is no healing. this patient had a history of ibandronate for 4 to 5 years for osteoporosis. So this is a stage 2. And then we have the more advanced cases where now the involvement is much larger. You may have a fracture, a pathological fracture, or almost to that point. Both of these patients are multiple myeloma patients. You can have extraoral fistula or swelling. These are 2 different cases, of course. But this patient here, for instance, is was one of the most wealthiest person in the United States. And his complaint was that he had seen everybody across the board and nobody could treat him. So he could deal with the public and his business and so on. So this is how much the quality of life when people develop this condition can affect them. Okay? You see in the bottom case, there was a fracture already, and there was a very difficult time for the surgeons to operate here to fix the fracture because all the bone was altered. And then where do you fix your screws and your plate and so on? And then again, the confusion with the Italians, where they claim that using the definition of the surgeons, you can misdiagnose. So they did a study. They look at cases from all over Italy using the definition by the maxillofacial surgeons, and they came about 24% of the cases that they could not confirm because they were using a definition that wouldn't include those cases. So that's why the discussion. But then is what the surgeons call stage 0, when you have a fistula, but there is a suspicious radiographic image. You can probe this bone and you will see that the bone is necrotic. Okay. Now, everything started with the bisphosphonates. Patients that we saw in the beginning, in the early 2000s, were patients on either alendronate, ibandronate for osteoporosis, or with the pamidronate or zoledronic acid for metastatic disease to the skeleton. So everything started with the bisphosphonates. And then came along denosumab that was used the same way, the Prolia for patients with osteoporosis, Exgiva for the metastasis. And now they have one called Evenity. And so the indications were about the same, and there are clinical trials trying to show which one is better, and the discussion continues. But for breast cancer, bisphosphonates are the ones most indicated. Then, in the beginning, we thought this was specifically an avascular problem. And if it was a vascular, the angiogenics would have a role here. And sure enough, there are different types of angiogenics that have been reported to cause osteonecrosis, and especially when they are associated with bisphosphonates in cases like renal cell carcinoma and kidney cancer, where the risk of osteonecrosis of the jaw increases tremendously when the drugs are associated. Then there were publications showing different uses of bisphosphonates, like other diseases such as Paget's disease, and then giant cell lesions, giant cell tumors, and so on. Amgen did a trial with denosumab that is now indicated for giant cell lesions. So the number of medications is increasing, putting a different population of patients at risk for this complication. You know, for patients with prostate cancer or breast cancer, to be maintained throughout the treatment, they are put on bisphosphonates because both the androgen deprivation therapy for prostate or the aromatase inhibitors can lead to bone loss. So patients then are put on bisphosphonates. And if you don't take a good history, if you don't work together with the oncologist, and you have a teamwork, then you may miss that because the patient does not correlate the fact that they're taking that medication with the dental care. Okay, so it's very important to emphasize again to work as a team. Never make a decision just by yourself. More recently, these are cases from Dr. Alex Wand from MD Anderson. This is a case of dasatinib, the patient who developed osteonecrosis. And again, there was just a fistula here, probed by bone, showing the area where the extraction was. And another more recent case where they are using now nivolumab with a PD-1 inhibitor, and the patient had melanoma metastatic to the left forearm and developed this severe area of osteonecrosis of the jaw. Okay, so you treat the forearm and the patient develops a mouth problem. And that's why we cannot work alone, because we're treating a person, not just a mouth or a tooth. And more recently, during the adjudication cases for Amgen, when they start the trials for the romosozumab, Evenity, which is now an anabolic bone-forming medication, we saw in the beginning signs that patients had suspicious cases of possible osteonecrosis. And sure enough, now this is a recent publication of a group showing several cases associated with Evenity. So now here you're treating the patient to form bone and they're developing the complication. So again, we have to keep our eyes open because medications are being developed all the time. And if they affect in any way the immune system or the bone metabolism, patients have to be considered at risk for developing this complication. And of course, in the beginning, the question was, well, is this osteoradionecrosis or ONJ? All patients that we saw in the beginning had no history of radiation therapy to the head and neck, none of them. So we had to look for other causes. That's how we saw that the common agent in every patient was the bisphosphonate. And we started to study that. So you differentiate because osteoradionecrosis, you have the radiation as the traumatizing agent. And in the ONJ, you have the medication. And in the literature, you will find descriptions of how osteomyelitis, osteoradionecrosis look like in ONJ, and that's why people are beginning to recommend a biopsy if you are in doubt. Take a sample and send to the pathologist. So in this paper here, they define osteoradionecrosis as a condition dominated by fibrosis and hyperexpression of collagen 1. And osteonecrosis is a condition characterized by a deviation from the normal bone architecture. And so if you think about the histopathology of osteoradionecrosis, you're going to have inflammation, you have radiation that leads to all those changes. You have changes in the vascularity, oxygen, and all of that changes the bone structure, facilitating the formation of osteoradionecrosis. We have fibroatrophy of the tissues, inflammation, fibroblast dysregulation, and you get to osteoradionecrosis. And I'm not a pathologist, but you can see clearly this case with bone necrosis with the empty lacunae and then the fibrous tissue. And this is courtesy of my former chair, Dr. Donald Cohen, that probably most of you know. He's retired now. And then the osteonecrosis is a different mechanism. Until today, there is, pardon me, there is a discussion on this, but basically we have to have some type of dental disease associated. We have to have inflammation or infection, micro changes, micro fractures of the bone. All of that together can lead to the osteonecrosis formation. And Dr. Cohen and his team, Dr. Bachakaria, Dr. Islam, put together some samples of cases that they received. They received biopsies from bone, and they started to look for differences in order to make a diagnosis of osteomyelitis or osteonecrosis of the jaw. Radiation, if you have the traumatic agent radiation, then you know how things are happening, why. But for instance, changes in the structure of the osteonecrotic patients with the lipping formation and the osteomyelitis, you don't see that. See all the difference in the architecture of the bone. You have also lack of osteoclasts in area of viable bone. So when you look at the osteomyelitis, you see the osteoclast activity around the bone. You don't see that in the osteonecrosis case. And then again, a change in the architecture where the lacunae are much more enlarged than in the cases of osteomyelitis. So this is, I think, a nice example. And that's why if you pathologists get a sample of bone and the patient is at risk for osteonecrosis, you must look like for these changes. So we're asking then, is it the time to confirm the diagnosis by taking biopsies? In the beginning, everyone was blaming the extraction for the cause of osteonecrosis. And I always thought, well, why do you extract a tooth? If it's not for an orthodontic reason, there has to be some type of pathology. Could be periapical, could be periodontal, or a combination. And that's why you have to extract the tooth. And then to me, there was already osteonecrosis or changes in the bone before the extraction. So we did several cases with my colleagues in Athens, and sure enough, patients who were at risk taking medications, you see pocketing, so the teeth that were extracted, and we curetted the ovellum, then look under the microscope, and we could see that there was already a change in the bones there. So there are new publications that confirm that. So dental extractions do not cause osteonecrosis. They may accentuate or turn the process more clinical. These are cases from Dr. Sukpin Wu from Harvard to show the changes that I talked about in the beginning. It's a patient on zoledronic acid for myeloma. And you see that sclerotic change here. See the same thing, different patient with 10 years exposure to both zoledronic acid and pamidronate. And for the orthodontist, it's a nightmare to try to move these teeth. Very difficult. Okay? So we still do not understand this process and how it contributes to the process. Now we come to the management. So how is that we're managing these patients? So if I'm here in São Paulo, I have a patient, I recommend straight to Dr. Caroli and say, André, you deal with it. He is my surgeon. So do we do medical management or do we do surgery? Today, it's your personal preference. And in my opinion, what is going to be less damaging to the patient, what is the best for the patient quality of life. So again, if I have a patient with either at risk or a patient with the osteonecrosis already, I will talk to the patient physician, with the oncologist, with the team that is managing the patient. If possible, when you establish a network and everyone has a good understanding about this, they will refer the patient to you before they put the patient on anti-resorptive therapy, angiogenic, if there is time. And that gives you the opportunity to eliminate all dental disease, or at least stabilize disease the best way you can. And that will reduce the risk of the patient developing osteonecrosis. Okay, so I always do this. I want to know the type of disease, how the prognosis is, so that helps me to determine what type of treatment I can do, and so on. Okay? And then I will put together my treatment plan based on all the information I got from the oncologist. That helps us, or the endocrinologist, or the rheumatologist, whoever is managing the patient for that particular disease. I need to know that information because it helps me the way I will manage and decide my treatment protocol. So if I decide to do medical management, I usually like to do this for early cases, early diagnosis. And then we used to recommend the stages 0 to 2, doing medical management with frequent follow-up, antimicrobial rinses with chlorhexidine. When there is active infection, we can use antibiotics. One of the signs here that is very important is the patient develops paresthesia. And from time to time, you can do minor local debridement and elimination of sharp bone edges that can cause trauma to the mucosa. And for instance, in this case here, a patient we saw in South Florida, a patient was the mother of one of my colleagues at the university, and my colleague and her brother, both were dentists, treated the mother because she developed an infection on the mandible and the molar, and they thought she had just a regular endodontic problem. Did the endodontics, did not resolve. They put a crown, had to remove the crown. When they felt that there was something different, they sent the mother to me. And the mother was a breast cancer patient, taking zoledronic acid for several years. And of course, she had the osteonecrosis of the jaw. And she had this area here that if I show Andre Caroli what to do, he's going to say, oh, we're going to extract the tooth, curette all this bone here, and then got healing by primary intention. However, the physician managing the patient told me, please don't do any surgical intervention. The patient has a very unstable AFib, atrial fibrillation, that's going to kill her. And we prefer that you manage the patient with the most conservative approach possible, okay? So that's why it's important to work together as a team. And so that's what we did. We just kept seeing the patient from time to time, curating. We gave her antibiotics. Erica used the lasers to try to disinfect the area. And one day, this from 2005, now 2.5 years later, the patient came back with the tooth, and there was complete epithelialization of the area, and she was completely healed. And this is the result, and just by doing medical management. Some of the surgeons, especially people who do not want to do surgical interventions, are using the same combination of pentoxifylline and vitamin E to treat the patients the same way they're treating patients with osteoradionecrosis. Medications are antifibrotic and they promote the healing of the area. The only thing is that may take a long time. My colleagues at the Memorial Sloan Kettering Cancer Center are doing this protocol, and they say they may take up to 1 year for you to see changes like you're seeing here. And these cases are cases from their study. And then the surgical management, where the surgeon is going to do resection, they do bone or soft tissue grafting, and try to obtain primary closure. So this is what has been used depending where you are and the protocols being used. Even in early cases, surgeons will be aggressive, intervene surgically, and try to obtain a primary closure the best way possible. So that's the change in the paradigm that I said in the beginning. There are different ways now, other techniques, some, especially the Italians, they like to do surgery and then they disinfect the surgical bed with lasers, or people who give the patient tetracycline to label vital bone. So they, in the surgery room, they can remove bone until the point that they shine the light and they see the tetracycline fluoresce. So they know they are now dealing with the vital bone. And teriparatide has also been used. So this is a systematic review and meta-analysis that was published in JADA in 2017, where they looked at several studies that treated the patient either medically or just with surgery, and they showed that there was a favor to surgery, which shows that it is fine to do treatment. And I see cases that André Caroli does here in São Paulo. It's just amazing the good results that they get. One question that I have been asked from the beginning, what about patients who are on these medications and need routine dental care? Okay, so can I treat them? What are the risks for them? Based on the studies that we have, people on the oral bisphosphonates, oral medication, or even Prolia, they are at risk of less than 1% to develop osteonecrosis. So you have more than 99% chance of doing treatment and the patient will do well, okay? For the patients with cancer taking the more aggressive medications, that the risk increases a little bit to like 2-3%, depending on the studies that you look at. Now, if you have a patient with the renal cancer who is taking the bisphosphonates with the anti-angiogenics, the risk could be up to 10%. And that's why it's important to take a good history. No, you have to know everything about the patient, because that will help you make a decision how you're going to treat the patient. So this is an 84-year-old female who came to us in the clinic because she needed full mouth extractions. You can see that her entire life, maybe she had one amalgam here and only extraction, so she was in very poor situation. She needed the full mouth extractions and dentures, and she couldn't only afford treatment in the undergrad clinic. She didn't have money to go to the postgrad or the faculty practice. So in her history, she had osteoporosis, diabetes type 2, high cholesterol. She was taking Lipitor, glyburide, and she had been taking alendronate for 6 years. And because of this, she had been to different dentist clinics and no one wanted to treat her. So she came to the university, which is the last resort that these people have. So we talked to the colleagues in surgery, and they agreed to follow the patient. The patient and the physicians decided that after so many years of alendronate, that was not going to change her skeleton osteoporosis as much. They could stop the medication, and then they decided on doing a stepwise protocol where they picked the worst area and did the extraction first, and then observed the healing. Healing occurred regularly, no complication. Then they moved to the next site and so on until they were able to remove all the teeth, work on alveoloplastic, and when she was ready to go, they were ready to do her dentures. There was absolutely no complications. This is 6 months follow-up after the extraction. Everything is healed fine. So she was ready to have a denture, and this was done in the student's clinic. Another study that we did was how much does a bisphosphonate delay the healing after an extraction? And so we followed several patients who came to our clinic and needed extractions and were taking bisphosphonates. And we followed them after the extraction without doing any intervention, just observing. And with time, there is healing, but there was delayed. The time of healing after the extraction, patient taking bisphosphonates can be twice as long, but it will heal. You just have to follow it up and maintain good hygiene and so on. So that brings us to today. After all these years, where are we? I did a quick search in February actually, and I just used bisphosphonates and osteonecrosis on PubMed. There were 4,478 hits, showing the incredible amount of research and publications that has been done since we first reported this complication. If you look at the acronyms, there are so many, I could not list all of them. But you have to know them because you know you're dealing with the same process, okay? There have been cases reported worldwide, and still today we have questions that have not been completely answered. So what is the exact mechanism that leads to the formation of the complication so we can develop interventions to prevent this? And then what is the most effective prevention protocol? Is it what I propose to you, or are there other ways? And then what is the most effective treatment protocol? Today we know that we can do surgery and have good results, but we can also do just medical management and still have good results. And we know that we have to keep an eye on new drugs that are being used, especially in areas of endocrinology, in rheumatology and oncology, that can alter the system in a way that will put the patient at risk for osteonecrosis of the jaw. So this is what I wanted to present today. It was just a panoramic view of this complication. And I don't know, I get tired of presenting this for so many years that I don't know how you guys don't. I hope you don't. But anyway, there are always questions, and I'll be more than happy to answer questions if you have any. Thank you so much.
Thank you, Cesar. Great talk.
I'm going to sit down.
Yes, please. Make yourself at home.
Thank you.
Okay. We have time for 2 questions or comments. Okay. So I'm going to make one comment that you talk about when you are taking new drugs. You have to keep your eyes open for these lesions. For example, we received a case, I think 5 months ago, a lady, 43 years old. She had a gingival lesion, and she was taking secukinumab, that is Consentix, for ankylosing spondylitis, and she developed histoplasmosis. So I think it's the second case in the literature. So we must report and must pay attention in this kind of new drugs that the people are taking. So I think your comment is perfect. So I share this case with you. What do you think?
Again, the important thing is you have to ask the question to the patients. They do not report to you unless you emphasize, you explain why this is important. You're not trying to be nosy that you want to know about them. It's just, it will help you to manage them the best way possible.
Thank you. Questions? Sarai?
Thank you very much. Do you have experience with leflunomide and osteonecrosis? Because leflunomide, the treatment for rheumatoid
No.
arthritis, we have a
Do you have
case
cases?
with leflunomide and
Yeah.
osteonecrosis.
This is a very important observation, and I recommend that people, when they see that, they publish, even if it's just one case report. That opens the eyes of the literature, so we can check when patients are taking those medications. We will be more cautious, aware that this is a possible complication. So I know nowadays it's very difficult to publish case reports, unless if you go to an open access journal that you have to pay $2,000-$3,000 to publish. But it is very important to publish, especially if it is there's nothing in the literature. Okay, so I recommend that.
Unfortunately, there is no my patient. It's a patient of other colleagues, oral surgeon, but it's the only reason. The flunomide arthritis and the lesion never healed.
Okay,
But
I'm gonna look it up to see if I can find anything.
I only find one report
Okay.
with leflunomide and osteonecrosis.
Thank you.
André, you were mentioned many times during the lecture, so please say something.
You're not supposed to ask me questions, André. Okay.
Obrigado. Dois comentários, né? Um em relação à questão da porcentagem, né? Então, acho que é um grande problema na questão da notificação, né? A gente não tem por hábito notificar ocorrências, então, muita gente atende isso. É uma condição hoje da prática clínica de muitos consultórios, né? A gente vê isso com frequência, mas isso não é notificado. Né? Acho que isso influencia muito provavelmente a uma subnotificação. Ouvir o professor César depois sobre isso.
Yeah, o André vinha me falando. André was telling me on the way here how many cases they're seeing, and that he's doing operations. And again, when I say the percentage or what is the risk, is based on clinical trials. There's no other way that we can do that. But some centers, like in Germany, they have a very good reporting of cases. Nationwide, people must report cases, and that creates a possibility of having a more real risk. But most of the times, I can only base what I say on the clinical trials. Yeah, Geronimo.
Hello, good morning. Just one quick question. We have found as clinicians that most of the papers of the scientific literature about all this pathology has in some way downgraded the importance of ONG in some patients. We believe that maybe because, for example, some really serious randomized clinical trials or systematic reviews have within the exclusion criteria patients with problems, dental problems. So they exclude those patients. So we believe that the prevalence of this pathology could be higher than the one reported nowadays. What do you believe about that?
Oh, I agree completely, and I can give you one example. When we first reported this, we were approached by Novartis because Novartis had finished a breast cancer study. They had over 3,000 patients, and they reported to us that this was impossible. This was caused by corticosteroids and not their medication, because in the trials they didn't see anything. And we said, well, you better go back and look, because did you look inside of the mouth? Or if the patient had a problem, did you just refer the patient to the dentist? But the dentist was not aware of what was going on. And sure enough, Anna Hoffman, who was doing the cases, the study at MD Anderson, went back and reviewed retrospectively all the cases, then they found several cases of osteonecrosis of the jaw that fit the definition we had at the time, and then they publish it. But I became persona non grata from Novartis because I was reporting something against their medication. But anyway, this happens a lot, and that's why I feel that it's very difficult to do studies. They're randomized, controlled. You need a very large N in order to have power for the study, and it's very expensive. So that's why only this big pharma can do the trials when they are testing a new medication. They want to have approval for this and that. So yeah, I think it's underreported, and that's why it behooves to us to see the cases. And another brief history. We published a paper together with the people from Northwestern University, and they were doing a study called RADAR. That they were following parallel what was happening with FDA, Food and Drug Administration. And we found out that the FDA had received over 300 reports of these cases before they decided to do something. And before they went to Novartis and said, you have to send a letter, dear doctor, and so on. So if it wasn't for the clinicians and the groups like MASC or Academy of Oral Medicine, Pathology, to report the cases, this would not have been discovered as early as it was. Okay?
Professor Migliorati, I just want to take this chance to thank you so much for your hard work on behalf of our graduation program. It's been more than 10 years that you have been hosting our PhD students in Tennessee and now in Florida. Many of them are among us today. So thank you so much for having us as part of your academic family.
It's my great pleasure. I think that's the way I can contribute to those who gave to me what I have today. I have to pass on this way. And it's so nice to be able to collaborate with people who are hard workers and publish and are always doing something new, discovering and so on. So it's a pleasure. Although I haven't been paid 1 cent for that. No, just kidding. Just kidding.
We would never be able to pay what we owe you, Professor Migliorati. There's no money that could cover that. Thank you so much. The same for Dr. Edgar Migliorati, who's here, also has been very, very instrumental for our program. Thank you. Thank you. So let's change gears now. I would like to invite Professor Alexander Pearson. Excellent, thank you. So good morning once again, everyone. It's my honor to introduce to you Professor Alexander Pearson. Professor Pearson is a medical oncologist by training, and he's also an expert in mathematics applied to oral sciences and AI applied to oral sciences. Professor Pearson is a full professor at the University of Chicago in the United States. He's formally collaborating with 2 PhD projects of our group. Both are sponsored by São Paulo Research Foundation. Ana Luisa, who's also part of the group, had the opportunity to practice with his lab. And today, Professor Pearson will be talking about the experience of his lab in the University of Chicago. Professor Pearson, thank you so much for coming. This is his first time in South America. He's a very special person and professional, and we can thank you so much. We cannot thank you enough for being here. Thank you so much once again.
Thank you so
Over
much.
to you.
It's a joy to be here. Thank you so much. I'm honored for the invitation to speak here and at SOBEP. I'm very excited to talk more with you throughout the day today. So these are my disclosures. So I'm a medical oncologist. I do research with pharmaceutical companies, and I have intellectual property for some of what we'll talk about today. The biggest disclosure, though, is that I am not an oral pathologist. So when you can raise your hand when I get into trouble and say something untoward, because I do not have training in some of the domains that I do research in. So we're going to talk about neural networks or artificial intelligence methods with applications for digital pathology. I'm going to try to describe a little bit about how they work, what they can do, and why they're getting so prominent. And we're going to talk about some of the emerging clinically facing neural network applications for digital pathology primarily. This is a shorter version of the 2 talks that I'm going to give later this week at SOBEP. So I'd like to start with a little quiz. So I realize that this is not either of our domains, but I want you to think about how information is going to inform decision-making, okay? So imagine you're in my position, which is as a medical oncologist, and you have to make a treatment plan on behalf of a patient. And you can either take information from column A or from column B, but you don't get information from both. And you have to make a plan about how to approach a patient's treatment. So you can either know that they're a 54-year-old man with a 30-pack year smoking history and a diagnosis of stage 3 head and neck squamous cell carcinoma of the hypopharynx, or you just get this imaging information here. So who's going to take the information from column A? And how about column B? Anyone? Okay, usually this segregates on who's an oral pathologist. And so I'm a medical oncologist. I'll take the information from column A as well, because I can mostly make the plans that I need based on this information. Now, let's change it a little bit, and you still get to only pick one. But instead of, in addition to the information from column B, let's say you can understand that a patient's tumor is p53 mutated, that they're a likely immunotherapy responder. But you have to pay for that additional information with a 4-week delay and $6,500 US. So now who takes the information from A? And B? Interesting. So I actually still take the information from A in this one, because in the US, we don't yet make decisions on p53 mutation status or immunotherapy response in stage 3 cancers. And this is both a delay and an expense on behalf of my patients. I'll switch it one more time. Third instance. Now, instead of the cost, we've replaced the cost with HPV with an HPV negative status and an assessment of recurrence risk. Anyone choose? So if it's now free, anyone choose information just in A, or how about B this time? Yeah, now it's all additive. And so I think the argument that I'd like to make is, if we combine the initial information from A and B using artificial intelligence, we can get everything here in column B with no added time and no added cost, potentially. That's at least the promise. So when we think about artificial intelligence, these are big terms. Artificial intelligence is, as I'll show, any technique wherein a computer or computational approach can make a decision similar to one of a human. And we'd say machine learning is a subset of artificial intelligence wherein algorithms are trained with data. What I'll organize most of my talk around is our emerging techniques using neural networks called deep learning, which are trained with data, but can accomplish, in some cases, superhuman tasks in service of our patients. So just to put that in an example form, if we were going to make a clinical rule, we might use clinical data to make an artificial intelligence assessment, meaning a rule-based threshold or cutoff to classify a patient as anemic by saying a hemoglobin less than 13 is someone who's anemic. We could use a machine learning technique to associate the degree of anemia and age using data to say that hemoglobin and age are linear correlated, and therefore we could control the assessment of anemia based on cofactors like age. And then we could extend further using deep learning to combine imaging and clinical data to say, oh, with a scan of a patient's retina, we can diagnose anemia based on a non-blood-based assay. And so in that case, we're using deep learning to say there exist image features associated with the presence of anemia. So the technology behind this, really what we're talking about is turning imaging information into digital information that we can process. And if there's the best time of day to think about intense mathematics is right before lunch, which is why we're doing it now. So effectively what we're doing is finding a process to take a picture, an input picture, and turn it into or correlate it with an output or a state that you want to understand or classify more. And one of the ways we do this is using a process called a convolution, which is a mathematical wherein we pass intensities of each pixel of information through a formula, a set of formulas called a kernel, into another more extracted layer of information, and then repeat this process through many, many layers so that a inherent understanding is built through these functions, through training these functions. And so effectively what that looks like is if we take red, green, and blue image inputs and we process the information, we pass, say in a 3x3 grid, we pass formula through that 3x3 grid and develop a new grid and do this in parallel many trillions of times in order to build an understanding. And the computer, as a computer is doing this, it's building component parts or a language of understanding through the accumulation of many, many instances of knowledge. So if you think about that architecture, that stack of planes of convolutional neural network layers, a computer first builds very vague and kind of fundamental shape knowledge, edges, planes, gradient fills. And it combines these in further convolutional layers or other architectural layers to make combinations of features that start to be recognizable. So this is data trained on faces from the internet, and you can start to see eyes and noses and so forth. And these kind of, we'd say, intermediate features can then be combined to form something much more recognizable, which are human faces, or the glossary of human faces, through these, in some cases, billions or tens of billions of parameters which connect all of these simple mathematical functions. So the thing that appeals to us is digital pathology is a great place to apply data-intensive projects because there's so much data in digital pathology. So this is obviously a zoomed-in expression of a pathology sample, wherein we can see through hundreds of millions of pixels the relationship between many different entities and actors relating to each other, interacting, and providing a context at many different levels, all of which can potentially be digitized using the right technology. So the flow, the way we process this information kind of start to finish starts with the standard glass slides, scans those slides. We might have an interaction with a pathologist to find a region that we want to focus on. We process the information automatically to parse and scan and normalize subregions to make this a computationally tractable exercise. We run our AI analysis, and then we can analyze the results, even treating the results or the output of a model as a language which defines the omics of visual data. And this is from one of our technical platform, which we call SlideFlow. But that, from the slide processing perspective, we take the standard slides that I think probably everyone in this room other than me is used to thinking about or interacting with, and we can process it to identify the region of interest, remove the areas of disinterest, extract components which are less appealing to our analysis, to set our grid, to pull the tiles from that grid through, and then to magnify the amount of data available to us, to normalize and augment the information, and then send it on to our computational processing. So all this can happen automatically and behind the scenes in order to get really high quality data from what is starting out a heterogeneous and real world subset of information. And so we've built over time a pipeline where we can choose from a given data set the type of cancer, the type of pipeline, the hyperparameters or the constraints of the model that we're hoping to train, and pair it with an outcome that's clinically relevant, like the type of data, the type of outcome data subtype, and maybe an annotation like some component, whether it's survival or mutation status or gene expression, for example. And this has allowed us to explore a really rich subset of different research concepts using the same core information pipeline for digital pathology. So just as an example, one of the things that we sought out to do was to build a next generation sequencing platform that made mutation predictions directly from the H&E slide. So instead of sending a tumor sample, for example, in the US, an advanced tumor might have a direct analysis to see what genetic mutations or genetic alterations it has in order to predict or pick a targeted therapy. And we sought to do that directly with an AI method, with the deep learning platform that we showed. And so what we did was build a model for every actionable genetic alteration in every cancer. And what we wanted to see was, can we predict some or all actionable genetic alterations that a medical oncologist would use on behalf of a decision-making for their patients, and have a model that predicts the outcome? And the answer is we couldn't. We couldn't do it totally, but there were many genetic alterations which we could pretty reliably predict across a lot of different cancers. And so, for example, I think many in this room who have studied oral squamous cell carcinoma will be familiar with P53 as a driver. Here's head and neck cancer down here. And we have an area under the receiver operator curve, which is a measure of a biomarker above randomness, as well as the false discovery rate correction on the y-axis. And a lot of the kind of recognizable drivers that we might be used to seeing, including HRAS and P53, were ones that we could predict those mutation statuses directly from the digital pathology slide. It would be like someone, training in this room looking and saying, oh, this, directly from the slide, this is this person has a BRCA genetic germline alteration directly from looking at their tissue. So we thought this was quite exciting. We've extended this to a lot of other domains as well. This is one of my physician scientist students, Sid Ramesh, and this is a model architecture we used to predict the progression of an oral premalignant lesion into cancer over a multi-year period using a contemporary architecture. And we found a very appealing performance of this model at being able to predict those individuals whose oral premalignant states are going to progress to cancer over a multi-year period, particularly with an incredibly high specificity on this curve, which might allow us to use a rule-in test and assign a treatment for those information. So at ASCO this year, we presented results where we used in a placebo-controlled clinical trial, we gave immunotherapy for patients with high-risk premalignant or recurrent oral cavity cancers, and showed that we could prevent the recurrence or new instances of those cancers in an adjuvant setting. And this might be the companion diagnostic that we could pair with that kind of clinical information and make a decision on behalf of our patients. So what's the heads-up display look like? So I'm going to, let's say you wanted to use one of the models we built within our platform. This is an animation that shows our SlideFlow Studio, which is our heads-up display that allows us to simultaneously look at the results of an AI model output, as well as the underlying pathology that is leading to the model decision. So what you're seeing is co-registered. You can see behind the scenes the oral pathology original sample itself, and then overlaid in the heat map, you can see the way the AI predictive model is calling the state. So this is a model for lung cancer that discriminates between adenocarcinoma and squamous cell carcinoma, and you see that it has different understanding or different prediction for different regions of the sample. And this same visualization technique, I'll show you later, can be used to look at other components like model uncertainty or model attention, which is a computational technique that mimics an experienced pathologist focus on the most relevant areas within a tumor. So this is what we imagine could be used as a heads-up display. If you're a pathologist, this is what it looks like at the elbow when you're running an instantaneous head and neck cancer model at the bench side. So thinking about extensions, I mean, I'm a clinician, not a computer scientist by initial training, and so a lot of the development of algorithms that I do is centered around thinking about what would help me or my colleagues in our clinical practice. And so this is a kind of a classic cautionary tale in artificial intelligence, where in the old days, researchers trained a model to discriminate a wolf from a husky dog, right? These are two animals that look very similar, but might pose very different risks to you if you encountered them, right? And so they were able, using pictures from the internet, to very accurately separate which ones were wolves and which ones were husky dogs. And so they used a technique called explainability analysis, which shows what the model is picking as accurate, okay? And they applied it to some of the results for the animal discrimination task. And what they saw was that they were not looking at the shape or length of the ears or the shape of the snout, but rather the model was deciding whether or not the animal was sitting in a living room or sitting in the forest, right? And this was really accurate to decide which of these animals were wolves and were husky dogs, which, that's all well and good for the discrimination task with this data. But if you were using this model faced with an animal in your living room that you didn't know, this could pose you a lot of harm, right? And the same goes for when we're making decisions based on behalf of our patients, right? If I'm using a model that has been trained with biased data or with correlations that aren't real or appropriate, then I might make a decision, if a model just uses information about what door a patient walked through on the first thing in the morning, I stand to do harm using an inaccurate or biased AI model. And so we wanted to understand if there were methods that we could use to explain and reassure ourselves that a model, one of these black box AI models, was in fact making a reliable assessment. So one of the things we did was use a technique called generative AI to build explanations. Generative AI, as you might have heard of, includes things like ChatGPT, includes things like AlphaFold from Google that makes molecules. And it's a set of techniques which can make synthetic new information out of trained data. So we used this generative AI concept to build explanations about a model trained on pathology molecular states. In other words, we trained a model in thyroid neoplasms to discriminate those driven with a BRAF-like molecular profile to those with a RAS-like molecular profile. And these two entities have very different trajectories, so you might make different decisions on behalf of your patients. We trained a generative model to suggest and smoothly interpolate between the pathologic representation of a BRAF-like model and a RAS-like model. And we can slide between the two states. And then we used a curriculum based on these synthetically generated digital pathology models to train US pathology residents at University of Chicago. So we gave them a test, or we gave them our standard lecture. We pre-tested them with these thyroid neoplasms on glass. We gave them a generative synthetic curriculum where they were just exposed to the labels and the synthetic slides, and then we tested them again. And their ability on a new set of left out glass slides to identify the molecular state directly from the glass slide increased significantly after exposure to these synthetic pieces of information, these synthetic slides. So that was reassuring, at least to us, that the model's explanation, or its exemplification of what it is thinking is important, is reliable enough that it can be passed back to a human, and they can improve their understanding of the underlying biology. We've done this as well with, I'll show, we've used this same explanation, and this is where I might get in trouble in this room, but this is the smooth interpolation between the oral premalignant states, interpolating between a non-progressor event to a progressor, and then back to a non-progressor. It's pretty subtle, so I'm not sure if it's, let me see if I can play it again. Oh, maybe I can't. Okay. All right, so if you see the proportion of cell subtypes kind of slowly and reliably creeps in and out as it changes. And this is a highly performing model. So we're in the process of working with our pathology colleagues to explain what these patterns are in the language of human pathologists. We're taking this concept, this encapsulation of knowledge concept a step further. And this is work by Fred Howard, who's junior faculty at University of Chicago, who came out of my group. And what we've done is now using a new set of technology called foundation models. These are things like UNI that came out of Faisal Mahmood's lab at Harvard. We can encapsulate the language of a real pathology slide in a single vector that's, say, 1,000 points long. And using that same reconstructive technology, we can rebuild a very similar vector, or a vector containing the same overarching pathological conditions directly from that derived feature vector. We can take it actually a step further, and this is what Dr. Howard calls a synthetic biopsy, where he uses MRI images and trains radiomic features that are correlated with pathology features, and then can reconstruct what the pathology will look like directly from the radiographic images. So it's a two-step transition. So, and he's interested to know if we can understand what the pathologic subtype will be directly from the radiographic images, maybe therefore saving us biopsies when unnecessary. One of the other things that would be very helpful for us to understand as oncologists is when we're relying on a model that's uncertain of its results. And so we call this uncertainty quantification. And one of the things we've done is to start building AI models which have sufficient recognition of their own uncertainty. So when can a model tell you it is not sure about what it should be calling? We do this by taking a model architecture and then cutting out little pieces and repeating it over and over, repeating the model training over and over again. And it gives us a measure of the distribution of variation for that model call. And this allows us to construct a measure of certainty or uncertainty or confidence, or not low confidence if you'd rather. And we can attach this to the model at the same time, so that if we exclude individuals for whom the prediction of the model is of low quality or low certainty, the model performance increases significantly. And these are high performing models at this range, but we effectively get a bonus prediction where for in all but the least certain models, we increase our confidence and we increase the likelihood that the model's prediction is correct. So I think that you might imagine at some future state where you are using an algorithm at the elbow to help to assist with diagnosis, you might have the opportunity where you get both the prediction, yes, it's cancer, and also, no, I'm not certain that it's cancer, which can be helpful to augment our kind of human brains. And here's what this looks like in real time. So this is a heads-up display where we're moving through an area and we're having a simultaneous assessment of an AI's ability to predict in a given zone, as well as the result. So as we moved through, I'll play that again. As we moved through, when the algorithm was in motion, it was not. As we move through, there's either no call or the heads-up display shows a red box which says low confidence, and you can see that this is calling an adenocarcinoma versus squamous cell carcinoma. But when we find a good region, the likelihood goes up, and the call is accurate at the same time. So this is how this works in a heads-up display, where we can give an assessment of the certainty at the same time as we're seeing the model call related to a region of active observation. All right, so I'm going to play a movie here. I'm going to try and play a movie here that is a full end-to-end encapsulation of what we imagine this might look like in deployment. And so this is with we've been playing around with this digital pathology scope called the Grundium. It's made from Nokia engineers in Finland. And so I'm going to show you a start to finish molecular prediction call directly from digital pathology slides. So what we're going to try and accomplish here is to predict, this is a model using for microsatellite instability. This is a hypermutated state in colorectal cancers, which is associated with immunotherapy response. This is the Grundium's heads-up display. So we see an area of where the digital pathology sample has been identified. We've clued into the region of interest just with a single click and then started the capture program. And so you can see that the Grundium device is scanning. This is a purchasable device. This is not something I developed in my lab. But what we're seeking to do is to deploy it to do something that's either would either require a separate immunohistochemical stain or multiple, or would be accomplished with a $1,000 next generation sequencing test in the US, which is that prediction of hypermutated states related to microsatellite instability. And furthermore, the model that we're using wasn't developed in our lab. So this is an open source model developed by the Cather Lab in Germany, who are good friends and collaborators of ours, who we've worked with for a long time. And so we just downloaded this architecture that they developed and open sourced in order for us to use. So at this point, the scanning has been completed, just while we're talking, of the whole slide image in high resolution, and it's been stitched together. And now we're exporting it from the software that the Grundium device has to the software that we developed, the heads-up display that we call SlideFlow Studio in our lab. And so these are big files. So it takes a minute to download. As you can see up here, this is all a networked device. The SVS scanned image in digital pathology is now updated or included to our SlideFlow program. And we make a region of interest, which is just the area to observe, excluding those pen marks and so forth. And then we generate an AI prediction, which is negative. So that was it. End to end in less than 3 minutes, we have a molecular classifier prediction that would for an endpoint that would cost thousands of dollars in the US and is done in 3 minutes for the cost of the microscope and open source software directly. So overlaid here are those other components. The certainty and the attention components can be toggled through on our heads-up display. And so that's our kind of aspirational future state thinking about how we might deploy this in a real world pathology setting. We're always asking ourselves, can we go simpler? Can we go cheaper? And so this is work by Divya Chowdhury in my lab. This is a 3D printable version, a many fewer bells and whistles than the commercial Grundium, but this is a completely open source, locally 3D printable microscope that you can have all in with all the components for less than $200, and with all of the software available for free. And we imagine this as a companion device or some format, some proof of principle that a companion device could be locally produced and shipped to any surgical center to accomplish some of these highly relevant pathology categorization tasks. Compared to a $200,000 microscope, it has incredibly high correlation from the model level AI calls. So we think it's that we're not losing a lot of fidelity in the capture component. So just kind of a food for thought about where we could be deploying these models and in real life. And so I do work all over the world, and this is the research team in Nigeria that I work with, and we train. We've been doing education for machine learning teaching to deploy these kind of low-cost concept models to low-income countries. All right, so why are we talking about this now? You've seen some of what AI can do, but why is it that did this all seem to happen kind of instantaneously out of the blue? And the answer is that there's a confluence of the perfect set of conditions to allow us to do this AI model creation, which has just now started to happen. The first is that we've had a huge amount of accessible, in my research area, cancer data. So the Cancer Genome Atlas provided, huge quantities, terabytes of data that can be publicly accessed and publicly manipulated for this sort of research. The second is that the method development, deep learning architectures which have these intense, highly connected and numerous layers allow us to process larger quantities of data with higher performance compared to older methodologies. The third is that we've got this, that the advent of high performance graphical processing units, or GPUs, which are the types of computers that can be used to actually do this AI network analysis, have become available and continue to rapidly increase in performance and efficiency. And the final factor is that these are now more than ever before. These are cost effective, so that labs like mine can build our own workstations for these kind of very specific domain challenges that we hope to explore. And the result of these four components is that there's been an absolute explosion in productivity related to deep learning. So this is just a search from PubMed of the term deep learning in cancer, and that where this is an exponential explosion in the interest in application space. And so that's what we've benefited from this. These are the artwork that a human did for me for each of the servers in my lab. And yes, they're all named after vegetables. And I don't know if anyone's old enough in this room to recognize the old video game Mega Man on the Nintendo. That's how we were inspired by our non-humans fighting cancer. So with that, I'll head towards the summary. So AI tools for diagnosis and early detection with digital pathology are both flexible to predict many different endpoints, They're highly performant. They're capable of both exploitation and uncertainty estimation. And we're looking towards seeing them deployed rapidly and inexpensively. So with that, I'll thank you all for hosting me once again, and thank my funders for helping to make this research possible.
Thank you so much, Professor Pearson. Any questions from the audience? Sure. Dr. Marcelo Esperandillo.
Hi, thanks very much for this presentation. It's eye-opening, as we were talking briefly beforehand. Obviously, we work here on the potentially malignant oral disorders, and you just shown us and explained to us the reasons why you should invest in studying them, because what we've been seeing so far, highly technological and perhaps very expensive ways of dealing with the lesion that primarily belong to poor people. So there is a contradiction there that wouldn't work, and I've just seen something that could do the job. My question is, despite that, you'll need lots of cases to develop a model that will be accurate. And in our experience, in order for you to have a certain number of cases that will be sufficient, will be a mammoth task, because we see 4 to 5% of malignant transformation in one of the most common types of lesions, which is oral leukoplakia. So I was particularly interested in the work by Sid Ramesh.
Yep.
And I was just curious, I don't know if I've missed it, but how many cases you had?
This was in collaboration with the U.S. National Cancer Institute. I'm trying to go back to that slide. And there was about 1,000 cases. It's a 3-institution repository, including a prospective study that the NCI ran, as well as institutional cohorts from the University of Iowa and the University of Chicago. So, and I'll tell you one other thing that I glossed over. Let's see if I can get there. I'm close now. Here we go. But I didn't overshoot. There you go. So you're absolutely right that these low prevalence events are super challenging, because this is a data-driven game, and just in terms of assessing performance, right? Like if you have a lesion and you know that 95% of the time it's never going to do anything. If I were a lazy algorithm, I'd say not going to progress. You know what I mean? Like just make that your base call, right? And you'll be right 95% of the time. So your accuracy will be decent. So number one is that I think that we are this 950 or so training cases plus 250 or so, maybe not 200 or so about external validation data sets was larger than many that have been pursued in the domain. That's number one. Number two is that we use this strategy in order to mitigate the inherent biases of doing small sample AI research. We leveraged this foundation model integration so that we have, there's this concept within AI, a couple of concepts. One is called transfer learning, which means that a model can be trained on one task and then be deployed on another somewhat related task in order to not have to retrain the model from first principles from the start. And the other, you can use a transfer learning strategy with something called a foundation model, which is a model that is trained with just gigantic quantities of unlabeled data. And it's not trained to a task, it's trained to tell you the language of the data set. So in this case, for example, we can use the UNI foundation model and plug it in here as a feature extractor, and a model that's been trained on 195 million images of digital pathology can be integrated and can pull out a language or a learned computer vocabulary of, say, 1,000 length vector for every tile that has seen, more images than a human pathologist will see in their entire career, not of oral premalignant lesion, but just of all the variation space capable. Now, this isn't a perfect mitigator of some of the technical biases that an AI model can have, but at least prevents us from like training to the distribution of, recurrences that happen in with one technician doing the staining compared to a different technician doing the staining. So when we switch to this format compared to previous strategies, our validation data, our validation results got much better. So I think those are some of the strategies. Bottom line, if you're going to use an AI model, though, it always has to be externally validated. These models are so lazy. We did this. I'll just give another example. I didn't show these slides, but we did a paper. One of my trainees brought me results, and he had trained a model to predict a patient's racial ancestry directly from their tumor samples. So you could predict if you came from a European or non-European descent, basically, directly from looking at the slides. And I was like, we're going to publish in Science. This is the highest impact thing I've ever seen. Until we realized that what the model was picking up, that the data set that we were using, which was the Cancer Genome Atlas, U.S. multi-institution repository data, all of the patients from underrepresented backgrounds either came from Chicago or from San Francisco Bay Area. So every African American in the data set was from Chicago, and every Asian American was from the San Francisco Bay Area, and everyone else was white. So that all the model was doing was predicting which technician, who was literally staining the slide with hematoxylin and niacin, back in the lab, and that was the only thing it was using, because it was a biased model. So we're very aware. We wrote some methods to get around that accumulation of bias, but we're super aware that that external validation, like we're showing here, is imperative. Otherwise, you'll make some very silly mistakes that have the potential to do harm. Well, that was a long answer on my part, wasn't it, to a single question?
Hi, Dr. Pearson.
Hi.
Thank you for your lecture. I was just thinking about this model that you present to us, that Sid developed, and I remember he tested in a subset of patients that we provide to you. So it's great to share to the audience that the model remained classifying really great. The accuracy remained basically 9%. The LROC, sorry.
Yep.
And I would like to just ask about the GAN-generated slides, because this is we kind of get worried about this artificially generated slides, these images that are generated artificially. So what is the impact of these slides? And we see this in an application of seeing the dysplasia in a period of time. So we have an image in the beginning, and then we can see how it evolves. So how is the impact to our area?
Yeah, so thanks. That's a great question. And what I was thinking, and you're going to correct me. You in the room are going to correct me when I say something out of turn here. But when I talk, for example, with Mark Lingen, who's my trusted pathology collaborator at University of Chicago, he tells me that the current way we evaluate the performance or the likelihood of an oral premalignant lesion to progressing is grading, right? Which is what we have, but it's also problematic because number one, it has a high degree of inter-rater unreliability, right? There's a lot of variation from pathologist to pathologist in terms of how they grade. And number two, even among high grade pathologist graded high grade dysplasias, that's a poor predictor of the actual, objective event of progressing to cancer. So what we were hoping to do with this technology is to see, okay, if an algorithm can accomplish something with a higher rate of performance than a human can, that's good, but we can also leverage this technology to learn more about the biology, right? What are the features that we can we, augment human grading with some new standards, or do we need to come up with some new language to describe the way cells look that hasn't been described previously, or maybe hasn't been included in grading, but maybe in a highly contextual setting? I'm thinking about things like the interaction between cells and visual features that would allow us an improved ability to understand what is actually happening in those progression events. So I think our interest in this domain is really to augment the prior knowledge that our pathology colleagues bring to us. We've started looking at, trying to look at those concordant and discordant cases, meaning come up with a language to describe those individuals that were predicted as, lower risk or lower grade but progressed in our algorithm, or were predicted as higher pathological grade and didn't progress, and see if an algorithm can show some of those subtle differences as we interpolate between those entities. So we view this very much as an iterative process with our colleagues, and this is the sort of thing that we would, we'd build 100 example images, and then we'd go back and we'd sit with Mark and Nicole Cipriani and their teams and say, what can we learn from these images? So it is not meant to be a standalone, but rather as a research vehicle.
Thank you.
Alex, can I ask you a more philosophical question?
How long you got?
No, we've got time.
Okay.
And we can't miss the opportunity to
Absolutely.
hear you. My question is about how you see the future of pathology laboratories when it comes to human resources. Because when you share the Grandian working with your model, I can see all the oral pathologists just trying to find a better place on their own seats. Everyone feels uncomfortable because this is groundbreaking. So my question is your personal view for the future about the human resources in pathology laboratories in general. Thank you.
Yeah. I think it's not going to be a rapid change, or at least as rapid as the technology has become available, but I think that there's going to be dramatic changes across all of medicine in the way that patients and patients' data interact with computers and physicians. And the example I'll give is can anyone in this room tell me the name of their favorite bank teller? Probably the answer is maybe it's some. But when I grew up, my parents had a favorite bank teller, someone they interacted with to get their money out, and I've never had a bank teller. Right? This is a change that happened previously. But when we look at things like satisfaction of interaction between a human through in-person conversations or via chat, there's a generational divide where, depending on your age, you might feel the same amount of kind of empathetic connection with your friend through a chat or a digital means as might be essential for me or people of my generation. So I see some social changes that are also going to make it more easier, kind of writ large, to interact, for patients to interact with the healthcare system without interacting with a human physician. So I'll put that on myself as well, where if I think about my kind of most pessimistic self, I imagine that there may be a situation in the future where most patient to healthcare system contact is done through an automated chatbot, and that you can pay an additional fee if you're capable of it, to interact with a human as well. You know, I'll put that. I think that's feasible, and especially as in the U.S., things like private equity and venture capital firms are now buying up radiology practices. So the largest employer in the U.S. of a radiology practice is a private equity firm. A private equity firm's entire job is to crank revenues up, right? If you have an algorithm that can replace a human by calling a pulmonary embolism or a pneumonia, you're going to deploy it because it's going to save you money. It's going to make you money. And so, as from a pessimistic view, I think that some of those, as we allow in the U.S. free market system that applies to healthcare, as we allow some of these agents and some of these financial incentives to become more active, I think that we're going to see certain vendors move to algorithms that can save money. So I think that that's one thing on the U.S. system. I think more worldwide, I think that algorithms are going to be an augmenting component rather than a replacing component. Or I think there's still going to be in most places in the world, the healthcare systems still need to grow, and I think algorithms for everywhere ex-US or many places ex-US are going to provide more capacity. So when I talk to my colleagues in Africa, my radiology and pathology colleagues in Africa, they say, bring it on. Just like allow us to train the models, make sure the models are relevant to the populations we treat, and we need all the help we can get as the major causes of morbidity and mortality, transition from communicable disease and famine to cancer in 2040 and after, that everyone is really receptive to computational methods that will help deal with that tidal wave of cancer, as it were, in the realms we deal with. So I think it's kind of be locationally dependent. I think that for example, the Page prostate, I think that the first algorithms are going to be just like they were in breast cancer and breast cancer mammography, I should say. The first set of algorithms that are going to be deployed in human practice and pathology are going to be ones that help with highly time-consuming tasks. So grading prostate pathology for Gleason score, for example, that's something that takes a lot of time. It's huge volumes in the US, and it doesn't require subspecialty expertise. I think those are going to be the first realms where there's a transition to a more computationally based approach. And indeed, the Page prostate has US FDA approval now to do that. So I had one other thought. That wasn't enough, but I had one other thought. So I think that in the next few years, I think that it's going to be the most common tasks are going to have artificial intelligence based analogs or companion pilots. But my radiology colleagues always say that every mammogram in the U.S. has now seen an algorithm. Right, so it's all done. There's an algorithm involved in everything. It hasn't replaced radiologists like some of the kind of AI luminaries said it would, and at least in the short and middle term, I think that there's going to be a increasing implementation, but not replacement of the workforce.
Fantastic. Thank you so much.
Dr. Bissell, thank you so much for sharing with us your experience. I have two questions. The first one is the challenging process that we generally have on creating the data sets. We know that in developed countries, we have a lot of challenging things considering the structures that we have. And in this context that you presented us about the multi-omics analysis and all the multi-analysis that you just performed, which are the main tips that you could give us in developing these data sets with this more accurate analysis? And my second question is about the large language models. Mm-hmm. You just presented us a very interesting study that you developed with your group. The larger language models just had a significant burden and your opinion about it, and how you can give us your tips on analyzing the medical fields and all this kind of stuff. Because we know that there are a lot of things that they can improve, since they, most of them do not have all the medical analysis and all this kind of stuff that are necessary to have accurate answers every time that we ask some things.
Oh, great. So the first question is about data set strategy, I think, or data set building. So I'll tell you that what I tell my, I will cover this at the SOBAP meeting, but I think that the biggest area of research in the next 5 years of AI is going to be in multimodal AI, which means models that integrate inputs from pathology, from language or clinical data, from imaging, all simultaneously, potentially. So when I think about building models just strategically as a first principle, I don't build them, I'm sorry, I said build a model. When I think about building a data set from first principles, I don't build any data sets without at least 3 data modes anymore. So that it needs an outcome that's clinically relevant, and it needs, some radiographic input, some pathologic input, some clinical or genomic input, or both, some different clinical, interventions or something like that. It has to be something where you're able, conceivably, to train all combinations of different different components. So you can train like pathology to genomics and clinical to outcome, all of them together to outcome, and it will help future-proof the time investment. So I think that's just starting from strategic principles. And then, I think that we view data set building as investment, and we invest in it just like my lab invests in data as part of a stock portfolio almost, that's and so we will make investments with grant funding in building data, and try and do it early, because this is such an active field that there's probably 2 or 3 groups in the world thinking of my most creative ideas, like doing them already, right? So I think that it's really helpful to do a journal review and see who else is if there are other people working in the space. So make sure that there's at least a moat around what you're thinking about. And then number 2 is make sure that you can collect enough data for it to be relevant. So, I think that my thinking on this has evolved. I used to do smaller projects with, say, 50 individuals. Now I won't do anything with at least 200 individuals, with a pretty even balance between 2 groups, or collaborate with colleagues, trusted colleagues in a consortium effort. But I think the demands, that's not to say that you can't accomplish things with smaller data sets, smaller size data sets. But journals, the barrier, the bar, the height of the bar to publish has increased pretty substantially in the last 5 years. And what you could get away with publishing in a really high impact journal 5 years ago no longer flies. Now you need multiple cohorts, all with at least 3 digits of individuals, multiple modes of data. And so I think just thinking about the return on your investment, I make sure that, we have constructed a data set that can accomplish those things. So sometimes that means thinking about, talking with colleagues at conferences to think about who's interested in what shared research domains. And sometimes that means doing a careful review of what the common things are at your institution. Did I answer that first question in terms of what you were hoping to hear from me?
About the medical fields, considering the large language models.
Yeah, the second. Okay, great. I just wanted so for large. I mean, certainly for large language models, my lab does not do large. I don't train or fine tune large language models, but I have close collaborators at Chicago who that's their whole expertise. So when we think about implementing large language models, I think we're more on like the evaluation side. So we've published articles looking at the use of large language models in in scientific writing or in abstracts for ASCO and so forth. And I think everyone is most questioning how to trust how to trust the output of a large language model, or how to control the output of a large language model so that it can accept flexible inputs and gives outputs with bumpers, outputs with constraints and without hallucinations. I mean, I think this is going to happen, and there's so much interest in it that it's moving very quickly. I think some of the new, what is it, MedPalm 3, or is it MedLlama 3, can now get a higher score on the oncology board exam than I can, right? Like it's the ability to return accurate knowledge has improved dramatically. And I think mostly it's going to be a question of how to most usefully integrate those models into the current system than it is about whether they work or not. I always find it a little funny that when someone's like, yeah, but it got 2 questions wrong. And you're like, it only got 2 questions wrong on the whole exam? Like, this is remarkable. And it took a human 30 years of training to do what an LLM with 7 months of training could accomplish. So it's not a matter of, I think it's a matter of how and when, not if it will be integrated. So, we're trying to build some very kind of tightly fine-tune some tightly encapsulated chatbots where trainees could ask very specific questions about a very specific knowledge base and get an instantaneous response back. So that effectively only saves you the time of good Googling, but it does that reliably, right? It's a single resource. So, I think that's an example of how I'm thinking about early and easy deployment into the real world setting. That might be like an example of the first pass, but lots of places in the US, well, I'll tell you, lots of places in the US have internal chatbots that serve as resources that are behind the firewall and that are not subject to medical liability evaluation. But I have, I can show it on my other talk. On my clinic on last Tuesday, I used an ambient listening device, and it dictated my whole note for me. It didn't dictate what was said. It summarized the conversation using a ChatGPT-4 backend. And it is a perfect summary of what we talked about in kind of medical notation format. And it did it automatically and instantly. And I didn't write a single word to summarize our encounter. So that it exists. I mean, it's ready. And I think that's another one of those kind of application ready components of an LLM that are already ready to go.
Do you think it just depends on the data mining process? Like the input that you send in the chatbot depends on that?
Well, I think it's, I think we're past the point, even in the last 6 months, the best, your performance from a chatbot was based on your prompt engineering. And I think now we're getting past that, where engineers from the purveyors have come up with formats where you're able to interact in a less prompt dependent way. Like, it knows that the abridged dictation software that I'm using knows that it wants to see my medical note in a certain format. It hears everything I says. It translates it into a technical, through a technical context, and it doesn't ask me what I need because it's been kind of pre-prompted to give it in medical format. So I think that is already a change that's taken place in terms of utilization.
Alex, thank you so much once again on behalf of our graduation program. What a fantastic talk. Thank you. We have to move for a lunch break now, but before we go, can I ask you all to come on stage to take a picture and to register this moment with our international speakers. Thank you so much once again. We will be back at 2 p.m. And Pablo, any other comments, any other final messages? Thank you so much once again. I'll see you soon. Vamos lá, pessoal, fazer uma foto para cima do palco, um pouquinho mais dinâmico. Vamos lá. Marco, Felipe, obrigado pelo suporte com a transmissão ao vivo. Muito obrigado. Vamos lá, pessoal.